So welcome to the bullfighting session. Thank you very much for all of you for being here. First of all, you need to have your application open because we're going to have real-time voting. You will be able to vote every minute. Okay? So you will start voting, and you can start analyzing exactly how all the audience is feeling about the presentations. In the application of the Congress, you go on the main screen, you go down on the right, you have the voting system, and every 1 minute you will have a screen saying vote. Every time you vote, we will start having the feeling of how the audience is sensing each presentation. You go on the interactive in the main screen, down on the right, okay? If you have any questions, you can ask on the back. So, we will start our first bullfight, our first full bullfight session. We're going to have Dr. Maria Jose Escafi from Chile. She's going to defend that preoperative preparation is fundamental to prepare the patient before bariatric surgery. And on the other side, we will have Marina Curian is going to defend the option that preoperative preparation is not necessary. So the rules are very simple. You will have 5 minutes to present. You will have then 2 minutes for discussion, and you will start seeing the voting system. So Marina, please come here. And Maria Jose, you have to start your presentation.
Okay, so I'm going to start tomorrow. Good morning, everyone. It is a pleasure to be here today. And I would like to take this opportunity to talk to you about preoperative preparation and convince you that is critical for good results of bariatric surgery. So please believe me, and don't believe Marina. This is a very controversial topic. We cannot delay bariatric surgery because it has been shown to be safe and remains the most effective and durable treatment for clinically severe obesity. We all agree with that. And I want to ask you something. From this auditorium, who could undergo bariatric surgery without prior preparation? You can do that? That's very scary, doctor. If we think about preoperative preparation, the first thing that comes to mind is the recommendation to lose weight before having surgery. However, this relationship remains uncertain. Let's start with some evidence, and here we have, I don't know if you can see that, but here we have articles from previous years. As we see in this article, a few years ago, the focus was on weight loss in preparation for BS. But this is an issue that has always concerned the medical community. And for that reason, research has continued, and we have another article regarding this. And it is about whether weight loss is mandatory in making a difference. What do you think about? Do you think weight loss is mandatory to make a difference in bariatric surgery? No, you're right. But we have to look further at that. And then we have another article from last year who talks about evaluation of risk factors for complication after bariatric surgery. And the last one from current years who talks about number of visits associated with low weight loss. So it's not important the time or the number of visits, it's important the effectiveness of our interventions in that controls. It is also very important to keep in mind that weight loss has to be supervised, because if it's not, it could lead to malnourished patients and increased mortality by itself. Let's not forget to maximize. I need the other. Can you put the other slide, please? Because we have to maximize fat loss while preserving metabolically active fat-free mass. Because we have to transform the quality of patient lifestyle in order to adapt their habits of post-surgery and correct any vitamins or mineral deficiency, improve insulin resistance, and get results in systemic inflammation. So it's important because one of the key issues during multidisciplinary consultation is to evaluate the risk-benefit ratio. And that's why we have to work together as a team. We will now focus on this article. I need that one. Thank you very much. It talks about eating. What happened after a bariatric surgery? For example, for you, doctor, who would undergo on this procedure without prior preparation, how are you going to live after bariatric surgery? Because we gather in groups, we enjoy eating, we calm anxiety by eating. But what happened at long term? That's a very important thing to consider. On the other hand, we have the patient expectations, who often differ of the expectation of treatment team. So we have to be able to give the chance to the patients to know the team who is going to treat them, and also support the patient, because it's a long-term treatment. The other one, please. Generally, for the patient, the medical motivations are often relegated to second position. That's why we have to teach them to make them aware that surgery is not the end of the disease, that obesity is a chronic disease that requires lifelong treatment and permanent control to avoid weight gain. It's not a surgery and that's it. So, as a conclusion, we can say the multidisciplinary team is key in selection the patients where benefits are greater than the risk, and identifying the subgroups of patients who require intensive management of their comorbidities. With an effective preoperative evaluation, the long-term outcome is improving adherence to multidisciplinary team, which could prevent weight gain after bariatric surgery at a long term. So we have to work together, and that's my last image. If you could put it, would be nice. The other one, please. Marina is making me so that. Okay, so now it's your turn.
Thank you. Dr. Escafi, thank you so much. While my slides are coming up, certainly neither of us are discussing the importance of medical preparation for surgery in terms of optimizing a patient's metabolic disorders and doing cardiac workup and all that. That is absolutely true. Next slide. We do need that. But I think our discussion really is about the preoperative diet. Can I have the next slide, please? Thank you. So, when we talk about preoperative diets in the U.S., we're troubled with our insurance companies that will not allow us to operate unless the patients show something. So we have some literature that we published basically showing that preoperative diet does not help at all. It doesn't change outcomes, and this is just one study that really looks at low-calorie diets, and there's no statistical significance between early complication rates and also long-term weight loss. Next slide. And this is a larger look, a meta-analysis looking at that. So preoperative weight loss, in fact, interventions were not associated with a reduction. Thank you. He wants me to win. Okay.
I have troubles also.
Sorry. Okay. So anyway, so preoperative weight loss not associated with any reduction in perioperative mortality, and there are also other studies that don't see any benefit of preoperative diet in what happens postoperatively. And remember our patients, this is what they're doing. 2 weeks of I have all my patients go on 2 weeks of a liquid diet, but this is them. And when they come in, they're like, well, I cheated a little bit, hopefully not with the rat. So my experience, it's good. I've done over 6,000 bariatric procedures in my career, and for the first 7 years, I didn't do any preoperative diet, nothing. Then when I changed institutions to be part of the team, I did it. The difference is that I had a very low complication rate beforehand, and I had a low complication rate after. I was able to proceed with surgery in everybody except one patient out of those 3,000 had too much of a liver that I couldn't get underneath it to do it. So preoperative diet is helpful. It's nice for the surgeon. We all feel better. Our backs feel better, our arms feel better because we're not lifting the liver, but it doesn't actually change our outcomes. And if somebody lost 30 pounds preoperatively or 15 kilos preoperatively, it doesn't necessarily mean that they're going to have a sustained long-term outcome. I want you guys to just think about what you do. We all have patients that come in. Sometimes I have to wait 6 months, so I see them every month, like Maria, Dr. Escafi is seeing her patients. Then I have patients who come in, did the 6 months, have the psych, the nutrition, I see them, and 2 weeks later we're in the operating room. So, and sometimes, I'll forego the 2 weeks and I'll say, yeah, you can do a week. It doesn't affect our outcomes because we know that a lot of surgery is what we do in the operating room. And certainly I would say postoperatively is very, very important. But how many times, if you would just think about your own experience, how many times have you operated on somebody that you met last week? And when you guys go back from this great meeting and this great session, you'll operate on them, and it's not a long-term commitment. So I think postoperatively, this is where we can really say there's a difference. We need, postoperative is very important, but patients have to follow a strict diet so that I think that impacts leak rate and long-term outcomes. When you look at who's a successful weight loser, the trajectory of their postoperative weight is very important to predict how they will do long-term. But preoperative diet certainly was never linked with any issue with pre-op. I wish this too. I wish it was all true. I wish it for my patients. I wish it for me, okay? But to my last slide, I will just say, when you talk to a patient and you try to tell them, as Maria said, Dr. Scaffi said, you want to train them. They don't hear anything. We all know this. Our patients don't remember anything, and we have to keep going over everything they're supposed to do, even post-op, when they're discharged, when they come back in to see us, and it's because of this diet. This is just something that they don't want to know, and after the surgery, when they don't have that hunger, when they are feeling that fullness, that is where their reality is. They really understand then that this is the change. And before surgery, you really can't prepare any of the patients for that. Thank you. You have 2 minutes.
Do I continue now?
A rebuttal.
Can I have the microphone here? So now you're going to have 2 minutes to debate, 2 minutes each.
To fight.
So now we're going to have, you can start voting. We will have votings every 1 minute. So whenever you want to change your voting, you want to change it while you have the discussion. Mufi, please, can you come here to the stage? Dr. Torres, please. We're going to have the discussion. So now, Maria Jose, can we have the 2 screens, one for the vote and the other one for the slides from Dr. Scaffi?
And he's here. The only one who votes.
Okay, so,
Sí, 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 tengo dos.
so can we have the next? Okay. Oh, okay, yeah, excellent. So, can we have presentation, the last two slides of Dr. Scaffi, please, to finish the presentation? And we will have in two screens. Leave on one screen the votings, and leave the other screen the Dr. Scaffi presentation.
So, Marina, I don't talk about diet, or I'm crazy, because I'm not talking about diet. I'm talking about lifestyle changes and eating behavior, and to have a support team to go through patient through life. So that's my point. So let me show you, this is seen from a movie, and let's imagine that the actress underwent bariatric surgery without prior preparation, and now we can see how she continues to order food like she was a patient suffering from obesity, because she don't have any prior preparation, and as from a cultural side, her partner presses it, and that's very common in our patients. So if we can show the video, please.
Ready to order?
Yeah. Can I get a double pizza burger, chili fries with cheese, and a large chocolate milkshake?
Nicely done. I'll have the exact same thing. You got it?
So that's my point. That's that we want to avoid for the long-term management of our patients. And on the other hand, we have some current literature who talks about a novel, a novel protocol on depends of the comorbidities of groups of patients. For example, some protocols for type 2 diabetes patients, some protocols for eating disorder patients, and some protocols for high cardiovascular risk patients, to do it for each group of patients. Not a diet for everybody. It doesn't work. And the next one, please. This slide speaks by herself, because in conclusion, I would like to emphasize that prior preparation is important, much more than the number of visits or preparation time. Focus on the needs of each patient, and this should be covered by suitable specialists who work together as a team. That's all I have to share with you all today, and I hope you believe me, please.
Marina,
yes, I'm ready.
Marina, you're losing, Marina.
Am I losing?
Come on.
Oh, she's so sweet.
You have 2 minutes now.
Okay, so 2
to defend
minutes.
yourself.
You know, Noah, the one you put up with Peter now on the preoperative esophageal workup, that was great, and thank you for putting that article up, but that article showed that with extensive evaluation preoperatively of the patients, only affected 24% of the patients after their decision to have surgery. So in that instance, with all of that preoperative evaluation, and they did manometry in that study, they did pH testing, and esophagram and endoscopy on everybody, what they found only affected the decision in a minority of patients. Preoperative workup is important. Optimizing a patient for surgery is important. But what we look at and what we do, our real focus is really that preoperative diet and how we're getting the patients ready. And I look at preoperative diet kind of like marriage. There's some of you are not married and everybody wants to get married. You don't know what it's like to be married until you're married. In a similar condition, you don't know what it's like to have the surgery until you have it. And so all the preparation you do beforehand is not the same as the reality of what happens after. I think Dr. Scaffi may not be. Oh, you married? Then you know. I'm just saying. Okay.
You did a good job, Marina. You're winning now. What's happening? So, Dr. Torres, what do you think about preparative preparation?
I'd like to ask a question to Dr. Scaffi. What do you do if a private patient came to you and ask to you, I want to be operated next week because I'm in a hurry, I want to go to Madrid to a very important meeting, and I heard from in New York there is a surgeon called Dr. Akurian that told me it's not necessary to do the preparative operation. And the patient is a private patient. You don't have 1 week, interval to operating on him. What do you say? I refuse to operate you or no?
No, of course not. We cannot delay a bariatric surgery. What we do is to put an intensive program and to educate the most that we can at that moment and work as a team with the patient to confront him to reality and to get real expectations and to let the patient know that VCD is a chronic disease.
I know, but you know that but the Dr. Kurgan there in New York told me it's not necessary to prepare before surgery. I'm in a hurry.
Too slow. I don't get it. I don't get it.
Okay.
Mufi, what is your feeling about the preoperative preparation for your patients?
So there are two sides of this dialect. Marina is like the surgeon who doesn't want any foreplay, just get into the act and just do it. You, on the other hand, want to take it nice and easy, slowly prepare your kill before you go in. What if Camilo were to tell you, I don't have time, I want to operate this patient tomorrow, will you still fight him and say, no, I will do this diet or this patient doesn't get onto your table?
No, he has to operate because it's a safe life treatment. We don't delay that, but we work very intensely on that patient. So we work as a team.
I think in general, preoperative, it's always the environment, but it's very complicated what you're saying, Antonio, that if your patient is private, that's saying if it's paying, if it's money, and I'm not sure that's a good option. I think the preoperative, you need to have a general assessment, and I think it's common sense at the end of this.
I think it's going to be this point, I don't know if Marina agrees with me regarding there is two different scenarios. One is the private scenario, another is the public health system like we have here in Spain. We have a long waiting list. Sometimes we don't know when we are going to be able to operate the patient. Sometimes we found, a space, a room for operating a patient, and,
Marina, you're losing
my
again.
concern.
I want to just say,
Marina, you're losing. Please, you have to vote every 1 minute.
Anyway, I will say this, though. There have been studies looking at preoperative requirements for surgery, and what they've shown is that the patients actually drop off because they have to see the sleep person, they have to go to the cardiologist. I think we're all doctors in the end. We know who needs to see the cardiologist, so we refer them appropriately. But when you have a lot of restrictions on how to get to surgery, many patients fall off and don't have the surgery. And I have colleagues that mandate 10% weight loss before the surgery. Is that necessary? There's no study that shows that you have to lose 10%. If they lost 10%,
that's very dangerous, Marina, because people can underwent malnourished, or maybe they can get sarcopenic, and it's a mortality risk by itself. We don't ask for a 10% of weight loss prior bariatric surgery.
I'm not saying that you do. My point is that it doesn't show any value. And the truth is we all have operated on someone that we met yesterday, next week. And preoperative preparation, your patient is not the same after surgery. Their soul, their view of food, their actual disinterest in food is very freeing.
Yeah.
And you cannot explain that to them before surgery because they have to experience it after. And so all of the difficulty in lifestyle and behavior modification, it's much easier to do when you have a post-operative program, not pre-op.
But it's very important to confront the patient to reality, because if it's not, then they have surgery and they don't know how to live before or after that. I'm sorry, after that.
I think everyone needs an
educate-
evaluation.
Okay, stop.
Stop.
The bull has come. Thank you very much for your preparation. Oh, Congratulations, Maria Jose. The last voting, please.
Well done.
Good to see you.
Well done.
So now we're going to have Dr. Carol Leroux. Next fight, this is a big one. New medication for diabetes will limit the spread of metabolic surgery. In a surgical congress, how can you dare to do that? So, stay here. Dr. Phil Shower. Where's Dr. Phil Shower? Yeah. Oh, no, you have to get the prices. You're in charge of the prices, Mufi, come on.
I refuse to wear this silly thing.
You have to.
Unless it gets me more votes. There we go. He's the bull. I'm the matador.
Okay, so
I think it's on that
we're
side.
going to start first with Dr. Karen Leroux, presentation Karen Leroux, and from the audio team, if they can give us a loudspeaker to us, because we don't hear anything when they discuss.
Do all the speakers get this? Yeah.
So,
Marie?
Karen Leroux, that presentation, please. So we have 5 minutes.
Well, thank you very much. I have the unenviable task to...
Sorry, Karel, you have to be on this side.
Okay.
You have to be on this side.
Okay.
Phil, you have to be on this side.
So I have the unenviable task to talk about medicine and how that is going to stop all new bariatric surgery. So I start with the first slide showing, it's time to rethink diabetes, but yet we have somebody performing an operation. That is the first problem. Diabetologists cannot comprehend the idea that surgery will be used to treat a disease that is inevitably, in their books, medicine. The story of Goldilocks explains this problem. You will remember that Goldilocks is a typical diabetologist. She walks into a house in the woods and she tries to have the 3 levels of porridge. The first level is too cold. The second level is too hot. And the third level is just right. Then she goes to the beds and there's the same issue. The first bed is too soft. The second bed is too hard. But the third bed is just right. The problem for diabetologists is the Goldilocks rule. If you ask them to do something that is very easy, like control blood sugar, because we have great drugs, that's not a challenge enough. But if you ask them to do something like use surgery to treat diabetes, that is too high. The real gold spot or the soft spot for the diabetologist is the new medication that's going to come out to treat diabetes, because now we can use the new medication like SGLT2s to reduce mortality. We can use the new medications like liraglutide and semaglutide not only to make sugar better, but to reduce mortality. That is something that surgery has never shown to do within a randomized controlled trial. This is the pipeline that surgery have to fight against. There is a number of really good medications that on its own is going to deliver weight loss similar to gastric banding. The benefit of medication, however, is not a single drug. The benefit of medication is when we combine different drugs with different mechanisms and we get effects much beyond what surgery can get. Any statin today is better than any operation when it comes to reducing LDL. The blood pressure treatments we have today is better than what surgery can do on its own. And that is the pipeline that surgery on its own today is fighting. Here is the biggest challenge. The SELECT study is a study for semaglutide, 2.4 milligrams, that is going to prove that treating patients with this medication is not only going to make them lose 10, 15, 20% of their weight. It's also going to reduce mortality in people who do not have diabetes. But look at the numbers. 17,500 patients needs to be recruited to this study. This is something that surgery cannot afford to do and cannot do, and therefore new medicines is going to reduce surgery in the future if surgery does not change. So over to you, Phil.
No, you have your own slides. You have your own.
Yeah.
Slide pass. So now we need the second presentation. Dr. Phil Schauer, please.
Here we are.
Okay, ladies and gentlemen, don't be fooled by my opponent. And as I said in my intro video, he is full of bull. Let me tell you, these miracle drugs that he's been talking to you about are way, way overrated, and I'll show you why. It is true, over the last 5 years, there have been a number of new diabetes drugs that have come on the market, specifically SGLT2 inhibitors and GLP-1 agonists, and this table does summarize some of their effects. Now, it is true that these drugs do have a very modest effect on improvement in macrovascular complications of surgery, but they're fairly modest in terms of MACE endpoints, all-cause mortality, stroke, and MI, and a few of them have a little bit of effect on heart failure. And this is the first time in history that drugs have been shown to have any effect at all, other than just lowering blood sugar. However, there are some major problems with these miracle drugs, my friend. Okay. Fundamental weaknesses of any medical treatment for a chronic disease. They cause minimal or no weight loss. You have adherence problems, especially with multi-drug therapy. When you start adding drug after drug after drug, compliance rates drop dramatically. Most have very modest improvements in A1C compared to surgery. You get about 0.5, 1% improvement, and that's about it. Modest improvements in comorbidities, macrovascular complications, and modest reduction in mortality. These new drugs are just like the old ones. Over time, the effect on lowering blood sugar wanes, and after about a few years, you find out that the patients are back where they started in terms of their blood sugar control. There's no difference here with these drugs. There are some major concerns, though, with SGLT2 inhibitors and GLP-1 agonists. Treatment effect is small. There's no long-term follow-up. These are relatively new drugs. Major side effects, which I'll talk about. Compliance issues, and they're expensive. They cost about $3,000 to $4,000 per year, and if you're on 2 of these drugs, you're close to $8,000 per year. You could buy a bariatric procedure for that in some countries, right? Okay, the treatment effect is small. Look how close. That's a tiny, tiny treatment effect compared to placebo. And I'll show you curves for surgery in just a minute. Look at the side effects of the SGLT2 inhibitors. A number of major serious side effects, and one of the more effective ones causes amputations. And this drug is probably not going to make it in the marketplace because of an increased risk in amputations. Now, let's quickly go through surgery. How much time do I have left?
One minute.
Okay, all right. You know about the randomized controlled trials that conclusively show that surgery is superior to medical treatment in terms of glycemic control. There are 20 observational studies that show massive treatment effects in terms of reducing mortality in the range of 30 and in some cases up to 80% in one study. And all of these studies are very, very consistent. And we have some brand new data that my colleague just 2 days ago presented at the European Society of Cardiology. Our experience in Cleveland Clinic with 2,500 patients with diabetes who had metabolic surgery compared to almost 12,000 controls who did not have surgery. And let me share with you the key clinical endpoint outcomes on these patients who mostly had either gastric bypass or sleeve gastrectomy. A few had banding, a few had duodenal switch. Here is the 6-component MACE difference favoring surgery, a dramatic reduction with a hazard ratio of 0.61, my friend. Okay, 3-component MACE, heart attack, stroke, death, favoring surgery, hazard ratio of 0.62, my friend. Okay, all-cause mortality, 40% reduction in mortality with surgery compared to controls.
1 minute.
And also reduction in new onset heart failure. And look at that difference in delta favoring surgery. This is a new finding, actually. So we have an abundance of information now with surgery being around for 3 or 4 decades now. We know how safe these operations are. They're extremely effective, and in no way do these new miracle drugs have come close to the effect that surgery has. How do you like that one?
Okay, so you have more slides, Carl? No? Okay. So the first voting, and we will keep on voting the next 10 minutes while they kill each other. Okay, Carl, 2 minutes.
So, surgery is dead. Long live surgery. What we have to do is we have to reinvent ourselves. If you look at your own country where you are working right now, with a new drug like SGLT2s or GLP-1 analogs, there's already more people in your country being treated with those drugs that have ever had surgery in your country. Right? And those drugs are less than 3 or 5 years old in many cases. So what we need to do is change, and we need to stop this argument about surgery against medicine. And we need to think, how can we make surgery better by using medicine together with surgery? And in fairness, Phil Schauer was one of the first surgeons to embrace this idea in his STAMPEDE study. And the reason why STAMPEDE is so good, and the reason why you will see that the hemoglobin A1Cs of STAMPEDE did not increase, is because so many patients use medicine together with surgery. These drugs are really, really good. When you combine them with surgery, it makes the drugs better and it makes surgery better. And in my opinion, that is how we're going to get diabetologists to accept surgery as one of their treatments. We need to make diabetologists understand that surgery is just as valid a treatment as liraglutide is or as empagliflozin is. And by combining these treatments, that is how the diabetologist is going to have benefit. That is how the patient is going to get benefit. If we don't do that, we're going to go the same way as the dodo. And we're going to have smaller and smaller numbers of surgery that many of you are already seeing in your own countries. We need to reverse that by looking also at the emotional side and how we get the combination up and running.
Can I have my slides back?
Yeah, can we put on one screen the voting? By the way, you are losing, Carl, at this time. You can make it better now. And on the other slide, we need Dr. Schauer, the same presentation.
Yeah. Now, ladies and gentlemen, although my opponent is full of bull, he's very clever. Because what he's trying to do, he knows he has a losing argument, so he's changing the debate. The debate is supposed to be medications will make surgery obsolete. That's what the debate is about. Now he's saying medications plus surgery. There's no argument about that, okay? So let's go back to the original debate, okay? Medications will not replace surgery, okay? And here's why. Here's the Schauer scorecard. All the key components of efficacy and side effects, surgery compared to medications. What happened here? Let's go back. Okay. Glycemic control. Obviously, surgery wins that one. Weight loss. Duh. Surgery wins that one. Effect on other comorbidities. Remember, patients with diabetes have all these other problems too. Surgery wins that. Medication reduction. Well, If your strategy is medications, you escalate the drugs. With surgery, you have the opportunity to reduce drugs, and reducing drugs is actually a good thing, my friend. Quality of life, surgery, clearly. Adherence, medications is a big problem. Short-term morbidity, mortality of the treatment. Okay, their medications in the short term may be a little bit safer, but in the long term, when you add up the reduction in efficacy and the increased complications of the medications and the disease, there I think it's at least a tie. Reduction of macrovascular complications, these have all been shown in studies. Mortality, all those favor surgery. Short-term costs, well, the drugs, short-term, in a matter of a few weeks and a few months, they're less costly than a $20,000 procedure. But if you're looking at the long-term for this chronic disease, surgery is much lower cost in the long run than these extremely expensive medications, which most patients can't even afford. So the debate is really superfluous because most patients can't even get those drugs. That's all I need to say.
Okay, so I just want to remember, you need to keep on voting because every minute you're gonna be the possibility to vote. Now we have 6 minutes of discussion. Carol, there's something to get about, so you're trying to be more, I told you that, you told me that you were trying to be nice to
surgeons. I think the ball is really stabbed. It's in the ICU.
If we think about the amazing evidence that all the randomized controlled trials have shown us how surgery in all the trials have outperformed medicine, my question is, why is it that all over the world we see surgery plateauing and in many countries going down? We have an inverse relationship between the evidence that surgery is better than medicine and the implementation of surgery as a treatment. So whatever we have done in the last 10 years have not worked. If we continue to do the same, what's going to happen is we're going to have fewer and fewer operations because medicine is inevitably playing a different game. Medicine has many advantages. It has disadvantages too, but diabetologists are comfortable in prescribing those medicines. Diabetologists are not yet comfortable prescribing surgery because we are opposing this, we are putting the arguments to them, choose between medicine and surgery. And if you do that for a diabetologist, they will always choose medicine because of what the future is going to promise.
I have a comment for you guys.
Wait, do I get to respond to this?
No.
I want to respond
listen to me.
I want to respond to this.
No, hold on 1 minute. I agree, all of us can agree that probably both approaches can be useful anytime. My question to you guys is, because sometimes, the diabetologist is prescribing medicine for avoiding surgery. And sometimes some surgeons are prescribing surgery for avoiding medicine. I agree with Carrera. My question is, what is the role, what is the order for treating the patient, obese patient with comorbidity? First medication and then surgery and then medication, or first surgery and then medication and then surgery? You know what I mean? So I think, being aware of that, Phil, I'd like to ask you, do you think there is a role of combining, and most importantly that is the order of this combination?
Okay, all right.
What are you going to do, first, second, or anyway?
First I want to respond to something he said earlier. Professor LaRue had said that surgery is decreasing or flattening. Where'd you get those numbers? Okay, the United States, we're receiving double-digit growth for bariatric surgery, and I think that's the case throughout the world. Raise your hand if you think that surgery is increasing in your country. Okay, Carol. What can I say?
I have a question.
But what about my question, Phil?
Okay, yeah. I'll answer your question.
Okay.
Yeah, it's a good question, but it depends on the severity of the disease that you're facing in the office. If there's a patient with early mild diabetes, of course, start with medications. Same with someone who's got mild obesity. But if a patient walks in your office and they're already failing medications, they're on 2 or 3 drugs, their A1C is 8, they're developing complications, their beta cells are burning out, don't wait too long.
Do you agree with that,
Too long.
Corel?
No, I don't agree.
He disagrees.
I think my colleague is not the bull. He doesn't have enough testosterone. I think you need to provide the treatment for the patient that the patient wants. If a patient walks into your door with pre-diabetes and says, I would like an operation, and they fulfill the other criteria, they should have an operation. You should not hang around with medications before and then proceed to an operation. You should do the operation, but you should be honest with the patient and say, none of us have a crystal ball that will tell us how much weight the patient will lose or how much improvement in glycemia the patient will have. So from the first consultation, you need to say the option exists that if this operation is not as good as we hope it will be, we always have something else that we can add medicine. Equally so, if a patient walks in your door with horrendous diabetes but does not want to have an operation, don't force the patient to have an operation, but say to the patient, we have good medicines, we're going to try our best, but if the medicines isn't good enough, we always can offer another option with surgery. So the point is, from the first consultation, make sure that the patients know they have both the options of medicine and surgery, but that many of them may end up in the future with a combination. So wherever they want to start, let them start with that, but actually be prepared to move on. Because if surgery does not deliver the weight loss that you want, the patient is not to blame. You are not to blame. It's biology. But don't forget the benefits of using medication to make the biology better. Adding medication after surgery is not failure of surgery. It is good medical practice. What we have to do is treat our patients better. We need more people to have surgery in the next decade. And the way we need to do that is to reposition surgery.
Okay.
I just want to respond just briefly. Yeah. So Professor LaRue says that doctors should give patients what they want. I think that's not correct. I will quote a famous philosopher named Mick Jagger. You don't always get what you want, you get what you need.
Rolling Stone.
Get what you need, yeah.
Rolling Stone.
There we go, yeah.
Phil,
Mick Jagger,
I have-
Rolling Stones. Yeah.
I have a question
Okay.
for you. I have a question for you.
Yeah.
I totally agree that numbers have been rising. However, metabolic surgery has not been rising. I have to be being honest. We spoke. The main concern this year in New York was that we are, although numbers in bariatric surgery are going up, we haven't seen the rise we expected for metabolic surgery, considering all the evidence that it's out there. And we have to be honest on that. What would be your explanation for that?
Well, I think data is always a key. I showed you some very compelling data. One thing that we do lack, and this is what cardiologists and endocrinologists live by, we do lack a definitive cardiovascular outcome trial, randomized controlled trial. We do lack that. And I think we might get that in the near future. And we do have that information. I think it's going to close the book on this issue completely, and surgery will rise to the position it should rise.
Carol, we have enough evidence there that the obese diabetic surgery probably is the best option. We've got DSS2, we've got various IDF publications, but no one wants to bite the bullet. Even today, if a patient were to go to a diabetologist, however severe it is, he will say, I've got another new drug. Like you said, there are so many drugs in the pipeline. Why would he not adopt an oncology principle and say, go get the surgery. If you don't get better, I can at least prevent end-stage renal disease. I can prevent various other things. Why is it still that physicians want to hold on to what they know best, drugs? And like Phil said, surgeons want to hold on to their territory, and it's almost becoming like a divide. Two parallel routes are not meeting.
It's a very good, and it has to do with tradition of disciplines. If you speak to an oncologist will never say to you that surgery is not a good thing, because an oncologist inherently understands that what he needs or she needs is they need surgery to level the playing field so that their oncological treatments can help the patient stay in remission in the long term. But diabetologists don't see it like that, because we have not presented surgery as a diabetologist tool. We've presented surgery as this is something that's going to make the diabetologist obsolete. And, you know, turkeys do not vote for Christmas, right? Diabetologists are not going to embrace surgery if they think it's going to take their business away. But they will embrace surgery if they think it's going to make their business better, not only financially, but also in the public system. And we haven't yet got that emotional switch. We have the data. We have the data to do that. We just haven't presented it in the way that I think we can.
Okay, thank you very much. Please, the last voting to see who's going to win. Again. Okay, thank you very much.
Very good. This is, you know, you are.
Okay, so we go to the next debate. The next debate we need here. 1 second. So now we're going to have Antonio Torres is going to present. So we're going to have Antonio Torres on this side and Dr. Loren Bierto on this side. Now we have to stick to the time because we are...
I think, you know, my position is going to be, Dr. Bierto, that this is the best option after failed sleeve gastrectomy. You know, there is no doubt that the sleeve gastrectomy is going to be one of the most performed procedures all over the world. So it's going to be very important, you know, to know that more than 50% of all the procedures all over the world are sleeve gastrectomy. So some of them can fail. It's just by chance, but approximately 30% of them will fail. So you guys are performing sleeve gastrectomy, think about doing a second operation on these guys anytime in their evolution. We have alternatives. We have medication, we have endoscopic alternatives, but we have surgical alternatives. Let's talk about the surgical alternative. Here you can see, you know, the list that all the alternatives that we have been using during those times. We can band in the sleeve, we can re-sleeve, we can plicate the sleeve, we can do one anastomosis gastric bypass. Let me have a breath. Duodenal switch BPD, SADI, SAHIS, bipartition, SASIN, and probably, you know, no, I'm missing some of them. But anyway, so it's the debate. So what about the result? There is no doubt that I can agree with Laurent that the duodenal switch is the champion. We have a lot of information regarding that after a sleeve and a hyperprimary procedure, long-term result, especially in very high BMI patient and very metabolic patient, DS is the best. I agree. The question is how not to do instead of two anastomosis, just one. SADI's procedure was conceived as to do a modification of standard duodenal switch. It's just to do one anastomosis, preserving the pylorus like the Roux-en-Y duodenal switch and with a known or well-known common channel. So the idea of performing one anastomosis duodenal switch instead of Roux-en-Y duodenal switch, two anastomosis duodenal switch is, you know, to try to lower the complication and rate and less secondary effect that the standard Roux-en-Y duodenal switch. So what is the reason of performing a Roux-en-Y? When we asked ourselves 12 years ago, we couldn't find a reason. It's just a costume. It was coming from Tom de Mister when they decided to do a Roux-en-Y for diverse bile for untractable duodenal ulcer. There is no other reason. Absolutely. You know, here our result 5 years in our patient regarding the BMI and the said weight loss. Very nice result long term with the one anastomosis duodenal switch. Here you can see there is no difference having between 200 and 250, And here is our result regarding the metabolic effect of the procedure. 5 years after the operation, here you can see how, those patients with SADIS procedure after 5 years, with complete remission, there is no medication, the hemoglobin C control, almost 72% globally were under complete remission of their diabetic profile. If the patient is using insulin before, only 47%. If the patient is under oral medication, 89%. It means that we have to reoperate a sleep patient metabolic earlier than we are doing now in terms of getting better results. Here, our publication, some years ago, our first 2 cases. Here you can see that at the beginning the patient did well after sleep, then they were worse, and then they was better after the second stage, after sleep gastrectomy, after the SADIS procedure. So here you can see the result: 72% except weight loss 3 years after the operation. So here you can see our updated data: 51 patients submitted to SADIS procedure after sleeve gastrectomy, mimicking the result 5 years that we got in the previous publication. 72%, 5-year result of control of getting a very nice excess weight loss of more than 70%.
One minute.
We collect all the sites, just to say very quickly, this is an old history. SADIS, standard duodenal switch, Billross 2, wrong way, you're going to be able. So does it make sense? Just one anastomosis. It's a faster technique, less anastomotic leak, no internal elimination. You don't have to close the mesenteric defect. It's easier to teach and easier to implement it. But I agree, this is modification of the system surgical procedure, preserve the sleeve, and have all the advantages of the duodenal switch with a better approach. We can teach the patient better, and so on. So this is my position. Here you can see you can fight against obesity anyway. I think that this way is one of them. But after a sleeve, if the patient fails, like this guy, don't do another procedure than do, a SADIS procedure, one anastomosis duodenal cyst. That's all. Lorraine.
Just in time, Antonio, perfect. Now, Lauren, you have 5 minutes.
Thank you. So, actually, I have to agree with Dr. Torres. I think he's...
Speak close to the microphone, please.
So, thank you, Dr. Torres. So, I think I have to agree with Dr. Torres. He's one of the top experts in the world on SADI, DS. He's a professor of surgery, PhD. And I think really when we have an expert talking about DS, we really have to follow his advice. So, we are very lucky. Last month there was a publication from an expert consensus panel, actually. They brought 30 surgeons from around the world. And wow, we've got Dr. Torres in the panel. So let's see what he's thinking, really. He was, I guess, a bit shy, so he didn't dare to tell us really what he thinks about DS. So, conclusion of this expert panel: as a second stage procedure, BPD-DS is most appropriate after a sleeve gastrectomy for the treatment of supermorbid obesity. 97% agreement, great. Or a subsequent operation for a reliable patient with insufficient weight loss after sleeve. 89% agreement, so good. So let's get a bit deeper. BPDS appears superior to other bariatric procedure in producing remission of obesity-related diseases, type 2 diabetes, hyperlipemia, and hypertension. SADI may play a significant role in the revisional setting in years to come, and it was published in 2019, so very interesting. Thank you. So, I think we have to look at the debate here. We're talking about, I like SADI as a one-stage operation, but we're talking about second-stage surgery. So this is a very specific population with severe recurrent disease, so it's not the standard one-stage operation. So I think we have to really base our decision in 2019 on the best evidence for the surgery. We were talking of randomized trials, so let's review the literature on the one anastomosis DS. So this is the data on the RCT from one stage, from one anastomosis DS. This is the long-term data on one anastomosis DS. And the prospective data on one anastomosis DS. So that's checked. Now, let's look at the long-term data on duodenal switch. So that's level 1A data, 5-year outcome, RCT showing the safety, the effectiveness of laparoscopic DS. Another RCT showing the effect on metabolic profile, 5 years outcome, RCT. Another RCT looking at the vitamin status after bariatric surgery. This is effect on cardiovascular risk factors, quality of life, weight loss. This is again showing the strength and the effectiveness, then superiority, I would say, compared to Roux-en-Y gastric bypass on weight loss and metabolic outcomes. Now, thank you for setting me the very nicely done study. So you look at the weight loss after one stage study. Second stage study. Now we can count together the number of patients at 1 year. There is actually 1, 2, 3, 4, 5, 6, 7, 8 patients at 1 year. So should we base our decision on 8 patients? Now, Dr. Torres might say, yes, there is another publication who just came a couple of months ago in obesity surgery. 93 patients, that's much better. Retrospective. Now, if you look at the fine prints, that's the decision again. We should base our decision on second stage DS. That's 50% follow-up at 18 months. So again, I think when you look at the data for second stage DS, we have better, stronger data, and sleeve is part of the DS for the last 30 years. So we have long-term data on the BPD DS. This is our outcomes, 81%. If you remember, we're going more at 65, 70% for one anastomosis DS. Remission of type 2 diabetes, especially for type 2 diabetes on insulin, you look at 83%. So, conclusion, we're looking at a very specific population with severe disease, recurrent disease, the long-term efficacy, and I would say even the efficacy at all of second stage DS is unknown. And there is very limited data for second stage DS. On the other hand, we have very strong long-term data for primary DS. So I would like to finish and quote my favorite author, single anastomosis DS may play a significant role in the revision setting in years to come. Thank you.
Okay, thank you very much, Dr. Bierto. Oh, this is no. You can we have again the slides of Dr. Torres? And
yes, please.
Please, can we start voting?
I agree with Dr. Bierto that we need time, Lorraine. We need time. But there is no doubt that you have a similar procedure. You can teach the procedure much better to the people. It's going to be much easier and going to be more reproducible in all over the world. That also painful fell asleep. But we need time. But in the meantime, we are waiting for that. Let me show you another study, another vision. But we need time. We are younger. But young people is coming. And young surgical approaches are coming. Here you can see, this paper published recently, by the Dutch group.
One second. Can we have the presentation on the main screen, and on the second one, the voting, please?
Okay, so let me show you this. I cannot see my presentation over there.
1 second. Yeah.
The presentation.
La presentación, ahí sí.
Okay.
Y votación en la otra, por favor.
Okay. So, no. Okay, can I pass through? It's the other presentation anyway. I can go through very quickly, just to the second part of the debate. So after that, okay. Let me show this paper, comparing after failed sleeve, Roux-en-Y, the trial that Dr. Bierto showed, Roux-en-Y and SADIS. 2 years, it's a few years. No medium-term result. But here you can see comparing 140 patients, 66 studies, 74 Roux-en-Y gastric bypass in a prospective multi-center way, because the procedure is very reproducible. And here you can see the data. The data is unbelievable. Even in the SADIS group are the heavier patient with BMI 49. Here you can see the result, the curve 2 years. Down, Roux-en-Y. Up, SADIS. Both procedures after failed sleep. It's going to be unbelievable, you know, how the patients submitted to Roux-en-Y after sleep are a plateau and then they go down, and the stability, you know, of the curve of the SADIS patient. Here you can see, regarding the total weight loss of those patients are significantly better with the patients submitted to study. We need time, 2 years, multi-center study, control in a very trustable country like Holland. And here you can see, the hypothesis that they are doing, Dr. Berthaud in his center, comparing studies with Roux-en-Y duodenal suite. So they are thinking something about going to be possible to do studies instead of duodenal suite. They have some question about that. So they have 250 centimeters, going to be a very nice study, but in this meeting, Dr. Berthaud told us, so we didn't finish yet our study, but SADIS has less bowel movements than the one anastomosis duodenal switch, maybe increased quality of life. And some more nutritional issues in Roux-en-Y. But anyway, we have to wait to complete the resolution of his study. That's all.
Laurent,
Yeah.
2 minutes to answer.
Yeah, I have a couple of slides to answer Dr. Torres. So if you
Can we have the
switch to my
presentation, the same presentation of Dr. Berthaud, the same one, the last two slides?
Again, I agree on the one stage DS. I think it's coming very soon as one of the standard, one of the accepted treatment for morbid obesity. I'm arguing on the question here for failed sleeve gastrectomy patient who have a recurrent disease. We are still in the infancy of second stage SADI. We're going from 200, 250, 300 centimeters, and we will probably, the question is one anastomosis DS the best surgery? I think we need data from a randomized control trial. So you were quoting this one stage RCT. Second stage RCT, I'm happy to share some of the early results with this prospective double-blind RCT. Patients are blinded for outcomes. Surgeons, it's another surgeon following the patient. So we recruited 30 patients. I'm presenting data on some 20 or 17 who had surgery. So surgery duration, yes, great. You save about 30 minutes. Hospitalization duration for SADI, you have a longer hospitalization. Second stage SADI tend to have more bile reflux in my experience, so that's a question. Weight loss, you see here, that's the excess weight loss, additional excess weight loss after DS at the bottom and SADI on top. So what you see already starting is that DS is crossing over the SADI, and probably, likely, SADI might plateau and stay there. Quality of life, we're getting to a quality of life oriented surgery. Again, you see SADI going across, the DS reaching and crossing over the SADI. So, yes, you have you're saving half an hour in OR time. You have patients stay another 19 hours in the hospital, and I'm really questioning the long-term benefits in terms of quality of life and weight loss, especially if you go with a recurrent disease with a 300 centimeter SADI. So I think we are still in the infancy, and I would argue that opening the door to 300 second stage SADI still needs RCT before we go for this. And
okay, I agree with you, Laura, but my question is, if the difference is going to be so huge, why do we have to do two anastomosis, close and mesenteric defect? At the end of the day, for many people, for the general surgeon, not very skillful guys, just do an anastomosis and go out. After the sleep is much more easy. The patient is not so heavy. Why do two anastomosis, close mesenteric defect? It doesn't make any sense, except long-term will be huge difference. On the other hand, very small difference. SADIS will survive and will implement it in the next years.
You have to prove me that
I have
that's
to.
the difference in quality of
But, you know,
life and complication.
I'm thinking on that. I'm thinking, you know, in what is the future. If a patient, one of you there, have a failed sleep and you come back there, you have two options. What to do? Do an anastomosis and crossing meningeal defect, or one anastomosis and crossing nothing? I can see the answer. You know.
I think we have to ask the patient. And if I tell my patient I have data from maybe 50 patients at 1 year, and I have data from 5,000, 10,000 patients who had DS, I think the patient
we are younger,
might
anyway.
consider.
Antonio, what do you think is changing a bit the question? What do you think is going to happen with the one anastomosis gastric bypass compared to the SADI, if you put that on discussion?
I think all the information we have until now regarding the one anastomosis gastric bypass as primary, as a secondary, after a failed sleeve, are thinking, and one anastomosis gastric bypass has some problem regarding marginal ulcer and some bile there, because the elephant is there. Is the elephant in the sofa? Where is the elephant? The elephant is there. You cannot see that, but it's there. The bile is there. So I think, if you can train the surgeon properly, I think they will be, the SADIS procedure will be much better. There's no doubt from a physical point of view. The problem is the one anastomosis bypass is easier. That's the main reason. And I understand, this is the reason I'm asking you guys, is you have a procedure easier and better, not so demanding from the skillful point of view, do one anastomosis duodenal switch instead of Roux-en-Y. Roux-en-Y have very selective indication. I agree with Lorraine, we need time, we are very young guys, and we are only 12 years old. Duodenal switch is coming here from many, many years, especially, the Canadian guys like Dr. Berthaud, they have huge experience, a very solid team. So answering your question, I think, that one anastomosis gastric bypass after failed sleep is going to be to play a role, but due to it's much more easier than the SADIS.
Antonio, you answered your question yourself. One anastomosis gastric bypass, the numbers are going up because it's one anastomosis as compared to Roux-en-Y. And that's the thing. Duodenal switch has got two anastomoses, SADI has got one anastomosis. So do you think that people have shown that they want to go towards the OAGB and not towards the Roux-en-Y? Why would they take a more difficult duodenal switch in a much bigger patient with a much lower anastomosis than a simpler SADI?
That's my point. You save 30 minutes in the OR, and then you have the question on your patient for diabetes, for quality of life, for the difference also is you have to follow those patients anyway. There is still some risk for nutritional deficiency, so you cannot just say, I save 30 minutes and I don't follow my patient. That remains a metabolic, malabsorptive or hyperabsorptive surgery, so you need to follow up. So I don't really see the benefits right now.
So okay, thank you very much. Thank you very much. The last voting, please. Come on. Oh, it changed. No, we're going to do one more. No. It was arranged. We have to pay now. Okay.
Who wins?
No, we have another voting because there was too few. It seems that it won Antonio at the end. So, thank you very much for the presentations, and we have to continue. We're way ahead of the schedule. So now we are going to have Dr. Alfredo Genco is going to present.
Lorraine.
Dr. Genco here. So,
the full is for you. Congratulations.
And Professor Michel Gagné is going to have on this side is yours. And this topic, this is a hard topic. This is even worse than the last one, Mufi. So sleeve gastrectomy is going to increase the reflux-related cancer. Dr. Alfredo Genco from Italy. And Dr. Michel Gagné is going to present that there is no evidence to support the increase of cancer for the sleeve.
My disclosures. So we see here these two cases of esophageal carcinoma, and this is endoscopy done after.
Can we put the presentation on the big screen, please? Okay.
This is two cases of esophageal carcinoma after bariatric surgery, and the endoscopy was done post-op. Two cases of esophageal cancer after bariatric surgery, but those two cases were after Roux-en-Y gastric bypass, intraoperatively after the anastomosis was done. No pre-op gastroscopy on this first case. Second case, 49-year-old male, no pre-op gastroscopy. So the cancer is attributed to the Roux-en-Y gastric bypass. We have some case report in the literature after sleeve gastrectomy. This case has no pre-op gastroscopy, 57 years old, 3 months later, developed a cancer in the esophagus. 3 months later, no pre-op gastroscopy. This case, adenocarcinoma, no pre-op gastroscopy, 44 years old, developed a mass, a pretty good mass, 18 months later, but the patient had dysphagia right post-op and was not investigated for 18 months. This case, after sleeve gastrectomy, is on a transplant patient, immunosuppressed, had vaginal dysplasia, vulvar neoplasia, and heavy smoker. 8 months later, carcinoma, but no pre-op gastroscopy. So, was this done by the surgery? No pre-op gastroscopy. There are 5 elements I want you to consider. If Roux-en-Y is so good against reflux, then we should see a decrease in the incidence of esophageal carcinoma. So there's this population-based cohort study in Sweden. This is over 900,000 patient years of follow-up. And look at obesity control versus bariatric surgery, and after so many years, there's no difference in the incidence of esophageal carcinoma. 3 out of 4 patients have reflux after Roux-en-Y gastric bypass. In this French study, looking at 4 years on the use of medication, it's not moving. Can you advance? Well, sleeve gastric bypass patients, sleeve went from 10% to 26%, and gastric bypass from 11 to 22% 4 years later. You can see gastric bypass patients, those that were taking PPI, 60% were still on PPI. And those who were not, 20% or so were on PPI. Sleeve gastrectomy had similar curves. This Karolinska Institute looked at over a longer period and data from Sweden, and they look at gastric bypass patients. And after 7 years, 50% were still refluxing and back on medication. So the effect of Roux-en-Y gastric bypass against reflux has a problem. Now, if we look at literature esophageal carcinoma, until 2012, we have all these cancers, and there was only 1 case of sleeve gastrectomy until 2012. In gastric bypass, quite a lot of cases, and in the remnant. Now, surgery was performed on 28 patients, and the mortality was 48%. So not everybody died from the cancer. Now, from 2012 to now, this meta-analysis was redone, and there are a few cases after sleeve gastrectomy, but a lot of cases with Roux-en-Y gastric bypass. Now, what's interesting is over 41,000 gastric bypass, there were 8 esophageal cancer. Over 39,000 sleeve, 1 had an esophageal cancer. So there were 8 times more esophageal cancer in the gastric bypass patient versus sleeve gastrectomy. Remnant can get gastric cancer, but we do sleeve gastrectomy, we remove 80% of the stomach. Now, gastric bypass patients followed for 5 years. What happened? This is an interesting study from the Kaiser Permanente over more than 40,000 patients. The mortality after 5 years of Roux-en-Y gastric bypass was 50% higher than sleeve gastrectomy, because of reoperation for all sorts of GI problems. You can see over time. Esophageal cancer looked in the province of Quebec, where we have 98% follow-up, national health care. They look at esophageal cancer after Roux-en-Y gastric bypass or sleeve and DS together.
1 minute.
There was no difference between the groups, and the incidence ratio of esophageal cancer in the cohort control, which is the Roux-en-Y, or the reflux-prone surgery, was not different over many years. Conclusion is that there was absence of significant difference in the risk. So long-term mortality concern, 2 times operative mortality with Roux-en-Y gastric bypass. There's 1% incidence of GIST. Bariatric surgery decreased cancer. So how many esophageal cancer you have to compensate this increased mortality? If we look at the 30-day mortality from NSQIP data, the mortality from sleeve was 0.1%, and in Roux-en-Y gastric bypass was 0.2%. So that translates in 100 deaths over 100,000. After 5 years, the mortality of Roux-en-Y gastric bypass was 1.9% versus 1.3% for sleeve. This translates into 600 deaths per 100,000. So now you have 500 deaths per 100,000. How many esophageal cancer with 48% mortality you need to compensate for those 500 deaths out of 100,000? So I don't see any reports of a lot of esophageal cancer in the literature right now, because over 2 million sleeve gastrectomy that has been performed. How many esophageal cancer have you heard? Thank you.
Thank you very much, Dr. Genko.
My slides, please.
Yeah, we're going to start. Dale.
Okay, thank you so much.
5 minutes.
Thank you. We know that the prevalence of Barrett esophagus in the European general population is no more than 1.3 or 1.6. In this study, in my study in 2016, in the study followed by Dr. Prager study, and in 2018, Dr. Yarnelli group, we found out that the incidence of Barrett esophagus, the prevalence of Barrett esophagus was 17.2, 14%, or 18.8%. In the United States, the American Society for Gastrointestinal Endoscopy says it is established that the Barrett esophagus is present in 1 to 2% of the general adult population. We know that the progression of Barrett esophagus to esophageal adenocarcinoma is influenced by many factors. These factors, genetic factors, gender, and other many factors. And the American College of Gastroenterology in this clinical guideline show how in 170 studies involving 25,000 of patients, they found that the incidence of cancer is 3.3 or 6.3. Mean value is 0.48. I don't go down in this slide to see what happened when the Barrett of the patient is a Barrett with dysplasia. No, we are speaking only about patients with the Barrett esophagus without dysplasia. In this population-based study involving a big number of patients, our colleague found that the Barrett esophagus subjects had a cumulative risk of progression of 7% at 7 years, and increased the risk of death from esophageal adenocarcinoma. This Professor Gagné showed these slides before, this paper before.
esophageal carcinoma after sleeve gastrectomy. Patient is delivered in June and the diagnosis of cancer in October. This means that our colleague delivered this patient with the cancer in the esophagus, for sure. But this case is a different case. Esophageal adenocarcinoma in Barrett esophagus after sleeve gastrectomy, case report in the literature review. A female, of 55 years old, who presented the lower esophageal adenocarcinoma, just 3 years after complicated sleeve gastrectomy, with the very known preoperative Barrett esophagus without dysplasia detected by gastroscopy. Multidisciplinary decision suggests to treat this patient with endoscopic mucosectomy that probably didn't work. Second case, esophageal adenocarcinoma 5 years after laparoscopic sleeve gastrectomy, case report. This is an old man of 48 years old with a BMI 48.5 with a gastroscopy pre-sleeve which showed absence of reflux or hiatal hernia, esophagitis, Barrett esophagus, Helicobacter pylori was negative.
1 minute.
After 5 years, these patients returned to the bariatric surgeon, referring dysphagia to solidity and 10 kilos weight loss. New endoscopy revealed this is what you can see here. A big mass of third of the esophagus. If we know that we performed 360,000 of sleeve in the world in 2016, and if we assume that the 15% of these patients develop a Barrett, 54,000 of these patients will present Barrett esophagus. If Barrett esophagus developed in 0.48% of these patients, 259 patients per year developed adenocarcinoma. Thank you.
So, Michel, 2 minutes.
Thank you very much. So he presented 2 cases out of 2 million sleeves. Can we show me the data? Show me the money. Can I have my slides for the 912? So I showed you in the study between 2012 and 2018, they had 8 esophageal cancer in Roux-en-Y gastric bypass. Because what are you proposing? That we don't do sleeve anymore and we do Roux-en-Y gastric bypass? Or we do nothing?
So can we put the presentation of Dr. Gagnon?
This is the paper from Dr. Jenko.
I'm voting, please.
And the problem is that only 1/3 were evaluated. 1/3 of your total cohort of patients were evaluated. So maybe the 2/3 didn't have any Barrett's. So that would change the statistic from 18% to perhaps 6%. Maybe you're over-evaluating. And is this metaplasia? Are we going to treat metaplasia? Are we going to aggressively treat metaplasia? Was there a second pathologist? Because we know the pathologist, evaluation of those slides is very important. Was it overdiagnosed? Were the biopsy done at the G junction? Was that stomach? There's a big question. And you have an effect of hiatal hernia repair. We repair a lot of hernia. In your own study, you showed an effect on your hiatal hernia repair. And the endoscopic treatment of metaplasia. Are you going to do this? Have you done this? Because this will change. Now, we have something for reflux. We can do links. We can do all kinds of fundoplication. We can do a heel repair, close the hiatus hernia, and then do an esophagopexy. This may have an effect on reflux. 93% are without PPI when this is being done. We can also do more and more hiatal hernia repair, while in Roux-en-Y gastric bypass, they're not being done without any significant morbidity. We have good drugs. We treat these patients with drugs for the reflux. In fact, there's a new drug that is coming around the block called vonoprazan. It's effectively super strong. It's in Japan, and this may come to us as a rescue against the formation of Barrett's esophagus. Links treatment. This is as good as complete fundoplication in a randomized study. This will stop reflux in our patients. Anterior foot application, Nissen sleeve, which has excellent data on controlling the reflux and weight loss.
Dr. Genko,
Yeah. Can you give me my slide, please?
can we start voting, please? Start the discussion. Yeah, you know, there's no slide.
And as I done the statistics, he would have to have 28,000 esophageal cancer to equal the 500 deaths from switching sleeve to Roux-en-Y gastric bypass.
Okay,
28,000
that
deaths.
is the truth. We submit to gastroscopy 5 years after the delivery, more or less 1/3 of our patients, because only 1/3 of our patients accept to be screened. Okay, even if the rest of the patients that we didn't check don't have Barrett, anyway, the 15% become the 5%. 5% is 4 times more than the general population. Anyway, this is what we have done last year. I had this data in my pocket since July 2018, and I didn't publish because I pretended to have and to see with my eyes the gastroscopy performed before this sleeve. In these 3 cases, we have these 3 patients. First patient is 60 years old, delivered in 2012 with the gastroscopy negative and with the diagnosis of cancer 4 years after this delivery. Second patient, 25 years old, delivered in 2015 with A grade of esophagitis at gastroscopy pre-sleeve that developed a cancer in 2018, 3 years later. A patient with 43 years old, delivered in 2014 with the diagnosis of adenocarcinoma in 2018 with the gastroscopy completely negative before sleeve gastrectomy.
What do you say to this, Michel? New data.
Well, you know, the development of esophageal cancer, we see that patients are male, age, and in Italy they smoke a lot, they drink a lot. So there are other factors, you know, societal factors that can cause cancer. And I would like you to do endoscopy in Roux-en-Y gastric bypass patients equally to find out that you may also have the same incidence of Barrett's esophagus, metaplasia, because in the 2012 to 2018, the incidence of esophageal cancer was 8 times more in Roux-en-Y gastric bypass patients. In fact, you don't know the incidence of this kind of metaplasia and done with other bariatric operations. I think that that's important to know. Maybe we're seeing the scaremongering equal to when we saw trocar site cancer in colon cancer in laparoscopy in 1995. So this stopped the development of laparoscopic colon cancer for 15 years because of scaremongering of this kind. So here I see this repeating itself again.
Okay, thank you very much. We have the last voting. Let's see. We will see who wins. Oh, it was close. Okay. Thank you very much. Thank you. So I want to call now to this panel Dr. Salman Al-Sabah, Dr. Joseph Vidal, and Dr. Lilian Coe. They're going to comment this next bullfight. And now I want to call Dr. Almino Ramos. We will have Almino Ramos, Dr. Ramos, oh yes, come on, our president. On the left and on the right, we are going to have Dr. Joseph Vidal. He's going to defend the position that revisional surgery is useless. Oh, that's a strong statement, yeah. Okay. And Dr. Almino is going to defend that revisional surgery is a reasonable option after failed bariatric operations. Thank you, Salman. Thank you, Dr. Ko. Almino, please. Can we have the presentation of Dr. Ramos? We are away, very out of the schedule. We are trying to go back on track. No, the other one, the other presentation.
This will be very quick, Camilo.
I know.
Just one round. Pepe, just one round here. I don't need more than one round, for this fight. Just one.
Okay, one round. You'll be dead in one round.
Okay. So now we need the presentation of Dr. Ramos, please.
Are you sure, Camilo, that this is for boys?
Yeah.
Huh?
That's what they use here in Spain. Don't tell me.
Pepe, I think that I need just one slide for you. So the discussion here is that revisional surgery is a reasonable option after failed bariatric surgery. I need just that one. So this is an article from Buchwald where he said that revisional bariatric metabolic surgery, it is a moral obligation to us. Number one, considering that morbid obesity, it is a chronic disease, failing to perform revisional surgery it's not fair. We should offer to our patients the second, the third, the fourth possibility depending the case. I want to ask you, Pepe, if you have a patient that you are treating the obesity, coming to your office for the second time and the patient is regaining weight, if you refuse to attend that patient, if you send home and we will not see it. Once metabolic bariatric care is initiated, we have to finish. We have to go to the end of the treatment with our patient. The patient deserves this kind of, we should be kind, polite, and human with our patients. But if you need a second slide, let me show you this that I think it's the most important article that we have about revisional bariatric and metabolic procedure. Again, you can see that the conclusions of this article, they are very similar what we have in the first proposal of Buchwald. So we are not treating an acute disease. We are not treating appendicitis or cholecystitis, that we remove the gallbladder or we remove the appendix and that's it. We are treating a chronic disease. And to adjust the treatment over time is part of the treatment of a chronic disease. So we have to offer to our patients the possibility of a surgical revision or any kind of adjuvant therapy for that one. We cannot accept any kind of policy coming from insurance companies or other kind of organization trying to not allow us to offer the best for our patients. And I think that's enough. I will stop here.
Okay. Now we have Dr. Vidal. This is the presentation of Dr. Vidal. Almino has been very, very clear about this.
So just let me make a statement first. I think that the debate is a little bit unfair because you had to defend something that is reasonable, so there's some moderation in there. I have to defend the position that this is useless, which is a very strong position, which is harder to defend. But if I can have my presentation on.
Vidal, presentación de Dr. Vidal.
I think that we were not invited to talk about moral. We were invited here to talk about what we do and about science and not about moral. And on the other hand, I think that we were not invited here to talk, that morality does not mean free drinks for everybody. So what we should be talking about is rigor in what we do. In my main message, though, is yes, patients may need some sort of revisional surgery, but this does not allow for a free drink bar, what's happening today. So what are we talking about? What kind of surgery? Are we talking about reversal for certain problems? Are we talking about corrective surgery? So for that cases that may be appropriate. Are we talking about two stages surgery? Or are we talking about conversion of surgery? And that's where some doubts may arise. So the indications usually are insufficient weight loss, weight regain, continued comorbidity, or comorbidity recidivism. And that leads to a new procedure. The question is, how we do define that? Is the patient who defines that? Is the surgeon who defines that? What's the etiology for that recurrence? What's the health risk associated with doing a surgery or not doing nothing? And finally, are there alternatives? The definition, I think we would agree, are oftentimes not well defined. We don't know how to define weight loss failure. We don't know how to define weight regain. What is it? Continued comorbidity. The etiology, we don't know. The health risk, oftentimes risk benefits are unclear. And the alternative have not been proved in randomized clinical trials, and we have heard a lot about this word today, randomized clinical trials. Remember that. So, and that leads to a new procedure. The issue of the definition. This is a systematic review of definitions of failure and revisional bariatric surgery. Different definitions. So different definitions, this sets for heterogeneity in the study population, so different outcomes. So this is a mess. So again, Kurkula showed nicely different trajectories. Are those trajectories based on different biology, different behavioral? So shall we apply the same procedure to these patients? Same revisional strategy? No answer to this question. Again, revisional surgery should be done, but it's a mess. The issue of health benefit. This is the health benefit associated with surgery in STMP trial. At 1 year, A1C dropped from 9.3 to 6.6%, and then went back up to 7.4% at 5 years. Number of medications decreased. So that's residual disease, 7.4 in Stampede. That was the residual disease we had. And roughly 70% of the patients being on 1, 2, or 3 medications. Well, now let's look at this graph here. This is an important figure when trying to indicate revisional surgery for persisting diabetes. This is the relationship between A1C and microvascular complications in diabetes. If in the STMP trial, the first year we moved from 9.3 to 6.6%, that's the projected risk reduction in retinopathy risk. Now, what if we had done revisional surgery in the STMP with an A1C of 7.4% and down to 6%? That's the size of the benefit. Yes, diabetes was there, but simply because diabetes was there, revisional surgery was indicated. This is the benefit you could be expecting.
1 minute.
The issue of health risk. This is a systematic review done by surgeons. Lack of high-quality data. 8.6% underwent a third bariatric surgery procedure, and 9.4% required a third procedure because of complications of the secondary. So, and the type of conversion, correction, augmentation, conversion, approach, endoscopical, surgical. So what's the goal? Oftentimes it's not well defined. So for failing sleeve gastrectomy, we just heard that debate on duodenal switch or SADIs. But the most commonly performed revisional surgery for sleeve gastrectomy still is gastric bypass. Dr. Ibarzabal will be showing this data in our oral presentation on Friday, but this is the data at 10 years after the revision. Gastric bypass is the red line, weight is the same as it was prior to surgery. So revisional surgery is not useless. However, would benefit from better definitions, needs to be considered in a broader spectrum of available therapies, and should be more rigorously indicated and evaluated. Thank you, Dr. Ramos.
So now we can start the voting, please. ¿Podemos poner la votación?
Almino, so you have 2 minutes to rebuttal.
2 minutes more?
Yeah.
Wow.
No arguments.
Pepe, you are asking us to stay calm. I'm very calm. But I think you are not feeling better today. You are a kind of nervous. What happened? Because you talk it. I could not understand. What are you talking about? We are here to talking about revisional surgery, not retinopathy, not diabetes. We are talking about revisional surgery.
Well,
so go back to my slides, please.
Dr. Almino,
the point that you asked.
Dr. Almino, this is not aesthetic surgery. This is
you are lost.
Health promoting surgery.
Pepe, you are not in Barcelona, you are in Madrid. We are in Madrid now. So, you showed this kind of slide. Where's the slide?
Can we put Dr. Ramos? Is right there.
You showed this kind of slide.
Yeah.
But look, we have a 4. The point number 4, that is the staged procedure.
Okay.
When you agree with your patient, okay, we will do the first step of the surgery right now. You are very risky, so we will offer you the second procedure 1 year later. So you are telling that we cannot offer what we agree with our patient.
Hold on a second.
I understand.
Hold on a second. Could you go back?
You have your 2 minutes. Okay, wait for your 2 minutes. Other issue is that I understand, and you said that we know as surgeon that the revision of surgery we have more risky. But look, we are prepared for that. We train for that. We have this very nice course. I go in the training center with Camilo and I train suture. I know how to suture. I don't have any kind of complication because I train a lot as a surgeon. Other issue here is that we know that we cannot expect to have for the second procedure the same result we have for the first one. But look, we are not looking just for weight loss. We are looking for benefit our patients with improvement of the comorbidities. And look, this article is very important because you can see that even you don't have so great or such great weight loss with the second procedure, you can offer a better quality of life to the patient. So now you can use try to do the impossible. Use your 2 seconds to 2 minutes to convince these people that we should not offer revisional surgery to our patients.
Well, don't take me wrong. I'm not saying that we should not be offering revisional surgery. What I'm saying is that revisional surgery...
You are saying that. You are here to say that.
Revisional surgery...
Assume your position.
Revisional surgery is a mess. And I'll be using your slides. Could you show the first slide from the SMBS
Go back on the slides of the same slides of Dr. Ramos, no? Yeah?
Yes.
Okay. Same presentation, no?
You know, he's trying to use my slides to justify his position. Come on, Pepe.
Tenemos que poner la presentación de Almino Ramos, la misma.
No,
La tuya.
Almino Ramos. So the point is, the first point is SMBS defines conversion and stage.
I said you are lost.
No, defines stage and conversion. Stage meaning something that you've planned ahead, and conversion meaning something you didn't plan ahead. And so and now you are confusing the two terms. Second, the paper you showed, one of the authors was Dr. Matar, was based on 56 subjects on one surgery and 85 on the other subject, if my quick lecture was correct. So, come on. I mean, this is a serious issue. It's not that revisional surgery is useless. Is it that revisional surgery concept does not allow for free drinks in the bar? It has to be developed, it's a field of knowledge that has to be developed with the same rigor as bariatric surgery has. And so far, it has not been the case. So, revisional surgery is not useless. It is what we are doing that is messy, and what we should be doing is tidying up the whole field and rephrasing what we are doing and showing the world that this data is worth. So it's not up to the creativity of the surgeon, but rather to the science of the field. And that's the whole point.
Lilian, what will you think, because I think this is a big issue. Revisional surgery is becoming a big issue and we have to deal with this from now on. What would be your statement? Because now Almino is finished as a president, so now you're going to take over now.
Well, I think there is a place, definitely, and we need to individualize it to our patient. So we've got to make sure that if we give them a revisional surgery, we are making sure that they are getting the benefit of the second surgery and not doing them any more harm.
Salman, because in Middle East, you're performing a lot of surgery and we are seeing more and more patients coming back. What is your position?
First of all, I'd like to congratulate both debaters, great debates. First, revisional surgery is an important topic, and I think we agree we have to have some standards and protocol definitions about weight failure and regain. And we have to, at this era, we have to think about precision medicine or personalized medicine. It is getting more popular, so we have to understand the patient from all aspects, from behavior, nutrition, anatomy, and also genetics. So I think we have to put all the spectrum together to have a better outcome for the single patient.
Almino, final comments about revisionals. Now not being so aggressive, now being calm.
I think that the point here is we have to look for a balance in between my position and the position of Pepe. This is a very serious issue for our patients. I'm totally agree that we have to look case by case. We have surgery is not the first option. It is one good option, but it's not the first one. So we have to study the case. We have to try to work with our multidisciplinary team in order to improve the follow-up of our patients. We have a lot of drugs that we can use, but if we don't have a good result with that, I think that the surgery with good, recommending in good cases, in cases that we know that we can have good results, it is a good option.
Okay, thank you very much. One last voting, please. Can we put the voting now? One last voting to see who wins, and thank you very much.
Yeah, but I think that to offer the continuity for the treatment, no matter surgical or clinical or other approach, it is our, as Dr. Bucco said, it is our moral obligation. We cannot refuse the patient.
I agree on it.
Okay, so, we did what we could. Thank you very much. So you have to give the bull to
So we call the next debaters, Dr. Lutfi
Well
and
done.
Dr. Francisco Rubino. Please come to the stage. So sleeve gastrectomy is a good option for the treatment of diabetes.
It seems that Dr. Lutfi didn't come. Oh,
Dr. Lutfi, where is he? He's not there.
So Francesco, you will start. Yes.
All right, I'll do it. Okay, good morning. Here are my disclosures. I do perform sleeve gastrectomy for some patients with type 2 diabetes. That means that I don't think sleeve gastrectomy is not a procedure that you could use for diabetes, but I do believe that in most cases, gastric bypass is the best option. So you just saw my opponent in this debate. He's a very smart guy. I think he's also very knowledgeable and is very honest. He does know that he has been given an impossible task. In fact, this is what he told me just last Monday. I'm in the airplane coming to Madrid, need to start finding a way to fight reality and make the point against bypass. So he doesn't believe any of the words that he's just about to speak. Why should you? Right? So, here is a little bit of refreshing of the data. In 5 minutes, I cannot do a full review of the literature. I will just tell you what people who have reviewed the literature have concluded. In the Diabetes Surgery Summit in 2016, the conclusion was that procedures that have been compared to diabetes therapies in randomized clinical trials are now accepted surgical interventions for diabetes, and those include both sleeve and gastric bypass as well as the other two ones. However, the committee of 50 people, all of them more intelligent than myself, have concluded that the gastric bypass, based on evidence, is the best option because it has the most favorable risk-benefit profile. And this is based on the following. Compared with sleeve gastrectomy, Roux-en-Y gastric bypass promotes higher diabetes remission rates. Level of evidence 1A. This means that there is a meta-analysis of randomized clinical trials where gastric bypass and sleeve gastrectomy have been performed for the purpose of treating diabetes. This is so important because when you heard before some of the speakers saying that gastric bypasses causes more long-term mortality than sleeve, across the board is equivalent to saying that total mesorectal excision for rectal cancer causes more long-term mortality than sigmoid resection. Which operation have you done it for? Which disease have you used it for? You have to say the disease and the operation. In this case, for diabetes, every study that compared the two in diabetes has shown superiority of gastric bypass, and also for other things like quality of life and other things. Of course, there is a higher incidence of some early postoperative complications that have to be taken into account. But all together, the benefit is favorable. The ratio between benefits and risk is favorable. There is a biological rationale. It cannot go through the many mechanisms, but if you look at glucose tolerance in rodents after a single bypass of the intestine without stomach modification, the glucose tolerance effect is better with a bypass. If you combine a sleeve with a bypass, that is even better. And so when you combine gastric and intestinal anatomy changes, like you do with Roux-en-Y gastric bypass, you get the best effect on glucose homeostasis. And in fact, this is true also in humans, as shown by the Stampede trial, where patients who have sleeve and bypass, even losing the same amount of weight, have much different and more profound effect on glucose metabolism when you do gastric bypass. The clinical rationale is based on the fact that an ideal operation for diabetes, of course, should control the disease, should address the biological mechanism behind, should reduce complications of diabetes, should also be cost-effective and reduce dependency on medications. But medications not only the ones for diabetes, but also the ones to treat the associated conditions. And here is the results of the Stampede trial, where you can see that patients with gastric bypass use far less medications for treating hyperglycemia, but also they use far less medications for treating cardiovascular disease that is associated with diabetes. So there is an important thing. Some people say there is a score you can use sleeve gastrectomy in less severe diabetes. I don't know what less severe diabetes means, but what you need to say is, are those scores that are used and proposed now based on remission of hyperglycemia, or do they take into account the effect on cardiovascular disease as we see that bypass provides in better way? So I'm going to just stop there and let my opponent see what, try to fool you with his own arguments. Thank you very much.
Oh, I'm sorry. I fell asleep, sorry. It's too much data. You done? I was not following. Sorry about that. Let me just wake up a little bit. Somehow my presentation got lost, so we know Camilo is
Maybe it's better for you.
There's some interference. And where's my presentation again?
Lutfi?
Here we go. So if you allow me, I'm going to make this a real debate, and I'm going to change the title from treatment of diabetes to treatment of diabetics. Because I think at some point we have to stop fantasizing about diabetes and start listening to our patients. And the invitation is also biased. If you look at Camilo, he put my title, sleeve is a good option, versus my good professor friend, bypass is best option. So they're screwing with your brains already. So Dr. Rubino is very famous, guys. This is the invitation I got to come to New York. Very interesting invitation. He's very, very famous. Me, I'm just a simple guy who comes to practice. I talk to patients. I look at the patient and I see what they want and how can we customize the treatment for their needs for this guy to look like this. And remember, this guy is different than this girl who happened to be 22-year-old with early onset diabetes. And by the way, in the next 10 years, she is going to get pregnant 3 times and regain weight, and then she'll be 7 years old. She has 50 more years to live, and I have yet to see 50-year-old data for bypass. While Dr. Rubino, way smarter than me, if you talk to him, this is what goes in his brain. He's always thinking metabolic pathway, way above my level. So I'm gonna just bring this down to simple. What the hell are we talking about? What is best operation for diabetes? What is the definition of best? Is it the best control, best survival, preventing amputation? We don't know. Hell, we don't even know how the bypass works. After 30 years, we're still talking between the proximal bowel hypothesis, the distal bowel hypothesis. We don't know what's going on, and we keep debating and going to meetings. And now, you know, our friend Dr. Whitgrove is talking about restriction again. They're not even talking about the GLP-1 and ghrelin. Everyone is tired. So while my friend chose all the randomized trial with the fancy names like Stampede, which I have no idea what it means, we have to remember, we have to look at the data and make sense of them. So yeah, there's some data very good data for sleeve. This is a new publication showing 70% at 5 years. They want randomized trial. This is you're very familiar with this. This is the early data for the Swiss study at 1 year, but then they followed up at 5 years, and they had 90% follow-up showing great result of the resolution of diabetes. Israel, the same paper. Even Camilo, when he's not traveling and he's working, he has done 800 cases between sleeve and bypass, and he's biased to bypass, but he writes that the bypass was longer and more complication because probably Ricardo was not there with him. So look, in Camilo's data, bypass was much better the first couple of years. At 3 years, the difference is gone because we know it's very complicated, the weight loss. Now, this is the Stampede trial, and if you look at those fancy figures, and at 2 o'clock in the morning, I was looking at these p-values. Look at this. I couldn't even see the difference. We are arguing about this. It's silly to come and argue about it. We need to stop. And at 5 years, the difference is also very, very minimal. We are wasting our time whining because we have more data that is not the operation, it is the disease. Data that talks about duration of diabetes, B-cell function burnout, how many medications we have, and this is his friend Phil Schauer, who supports him, showing that at 6 years after sleeve,
breathe, 1 minute.
1 minute and a half. Hemoglobin A1C does go up, but it's still acceptable at 6 years. And the p-value that everyone is obsessed about is significant. It is the disease again and again. It is not the operation. Gastric bypass worked well for the first year, but my friend, Dr. Rubino, sees a patient when they're smiling. At 12 years, he's traveling in Singapore somewhere, giving a talk, and does not know that 12 years later, this patient had bypass, the bypass diabetes occurred. This is the last thing. It's interesting, people who cross over from being pre-diabetic to become diabetic after surgery. Sleeve and bypass are the same. And the only thing that's different is the weight loss that determine. It only correlates with the weight loss. That's reality, my friend. And if you cannot understand that, that's easier to see for you to understand. The green and the gray, they are the same. They are the same. So let's treat this just like medical people with medication, escalate the therapy. And I'm gonna, this is my last slide. This is the two arms. For younger patients, early diabetes, there's no need for a bypass. For older, very bad diabetes, where you guys do bypass, the pancreas is already burned out. So you can do bypass on these people in the middle. But the reality is, this is the reality. Most of our patients belong to the right and to the left. So I would, if I were you, I would stop looking at the p-value and data and start looking at the patients.
Yes. So, 1 second, we will start the voting. So please put on one screen the voting and on the second screen the presentation of Dr. Rubino. Continue. So Francesco, you did a good job.
Yes, absolutely. I told you guys he was a smart guy, he would have done a good job, but he doesn't believe anything about what he's saying. So I don't know why you should believe him too. But anyway, can I see my slides, please?
Yes.
I just want to show two things.
Slides. Rubino, back to the presentation of Dr. Rubino.
And I just want to say that I have a dream. Sounds like a big statement, but I do have a dream. And this dream is that one day we will move, finally, we will make the last step into what brings us into metabolic surgery for real. And that means recognizing that we're treating disease. And treating disease means we have to understand that we're not just dealing with a chronic disease, but we're dealing with a chronic and progressive disease. So diabetes is not just chronic, it's progressive. That means that you cannot hear nonsense statements, including nonsense postures, like you do a sleeve now, you will do a gastric bypass later. Because a few years after, the disease is no longer the same. You have to shoot at diabetes with the best possible weapon you have as soon as you can, because diabetes does not wait. So if gastric bypass has been shown as it has, that is the best possible option, that gastric bypass should be for most patients the best possible option. Not because sleeve is simpler, it does not make sense. You don't do partial gastrectomy or total gastrectomy because one is simpler than the other. You do that depending on the disease stage, and with the intent of preventing a disease that is progressive and can do further harm. You cannot delay treatment. You cannot postpone the treatment. So that's why gastric bypass is the best option. Now, you can dance, but that will not change that reality.
Can we call them?
Again, I have no idea what you just said. So let's put my slides to have real slides.
Go back to Dr. Lutfi presentation, please.
That's too complicated for me. I don't even understand it. This is good. Everyone is awake? Data. We keep talking about data. Here we go. Sorry. All right, so I am tired of this whole data thing. We need to connect with patients, my friend. Ghrelin, leptin, blah, blah, blah. Listen, yes, you're right. Roux-en-Y for diabetics who failed VBG is great, 90%. After gastric band, great, 70%. Even after sleep, great, stage procedure is excellent. But look at this revision of actual bypass for recurrent diabetes. When you actually trim the pouch, 70%, what happened to all the metabolic stuff? We didn't change the ruling. We didn't do anything with the bowel. We just went back to restriction. And 70% plus of these diabetics got better. Listen, you're selling the best product to an audience who don't care. This is real data. This is what patients are seeing. And if we don't recognize that, it's a problem. And it's not only in the US. It's every place. This is your IFSO. Every country in the world, this is what's happening. We need to connect with our patients. But let me tell you, my friend, if we want to plan for a better future, we must understand the past. Bypass is great. I do mostly bypass. We're here for fun. But look, when the ban came out, it was a gift from God. Everyone wanted safer operation. People didn't care about the data. Everyone wanted the ban. But then when the ban went down, only then the bypass went back up. And there's this little guy called sleeve. So when the sleeve started going up, again the bypass went down. And you guys start whining about reflux and diabetes, and all the marketing companies on all the industry thought the sleeve will go down and the bypass will go up. Hey, reality check, it didn't. It is not happening. People do not understand the complex data. We have to connect with them because this, my friend, is a bad thing that does not happen with sleeve gastrectomy. We know that the bypass is better, but this is my final suggestion. This is your friend Phil Shower data, right? This is the little p-value. Look at this. You show yourself. If you think gastric bypass is better than sleeve and we should go, do a switch. Look at the difference in your data from a bypass and look at the difference from sleeve. If you want to go for the best, do a switch. This is your data. And now we can even have simple switch that even a medical student could do. Do a switch. If you want to do bypass because it's better than a sleeve, do a switch because it's better than a bypass. Boom.
Can I have just a short debate? Okay, so you say that people didn't care about the data, they just the gastric band, and probably the same has happened for sleeve. That's 20th century bariatric surgery. We are in 21st century, if you haven't realized that. And this is metabolic surgery, and this is another business, this is another game. Data matter, lives matters. And disease and diabetes is complex, is complicated. We can't just say data doesn't matter, people like one operation or another. We need to confront a disease, and we need to also speak to our colleagues diabetologists with the same language, which includes looking at the data and understanding the data, which requires a little bit of time and passion.
I agree with you, and that's an excellent point. If I may, obesity is a chronic progressive illness. We have all been humbled by obesity. We have done perfect operation that worked for years and then saw the patients later with weight regain. And we tried to cut away their pouch. Manuel Galvao wants us to throw endoscopic stitches. Obesity is humbling. And unless we admit it's chronic progressive illness, we will fail to connect with our patients and we'll stay at the 1%.
Lillian, what is your opinion about this?
I've been very well entertained, I think. On one side, we have facts. On one other side, we have entertainment. I thank both of them.
I'll take it as a compliment.
Salman.
I think it's a great debate. I would like to thank them for a great debate. I think we have as Dr. Lutfi mentioned about the sleeve, I mean, it's a great procedure, but also it's, as Dr. Rosenthal says, it's a easy procedure, but it's not simple. So we have to be careful with the procedure in terms of its complication and long-term outcomes. And I agree with the science. I think we have to put the science with the technique together to deliver the best option for the patient.
What do you think, Francesco, is happening? Why we are not seeing, considering the mechanisms you've studied so much, I thought that Stampede would show a stronger difference between bypass and sleeve. Do you agree with that?
But I think Stampede did show a difference because when you show those graphs, as I said, you're showing just the tip of the iceberg. The reality of the Stampede was that the patients were achieving relatively similar A1C level, but with far less medication. You can't tell me that that's the same thing. They were taking far less cardiovascular medication. They had much better quality of life, at least at 3 years in the first 1 year. Those are not trivial outcomes differences. So when you show just the graph of A1C levels, it's like if I told you you are at the same body weight, but you're taking a medication, millions of medications, and another one is just doing lifestyle intervention. It's not the same thing. So those patients had much better clinical outcomes, and the STAMPEDE has shown it, even though the STAMPEDE was not designed to show that difference. But the power of bypass is such that even in an underpowered study, the difference shows.
Okay, one last comment. Please vote again. Can you put the voting again, please? One last vote, and we will. Yeah, you're almost there, Francesco. You're almost there. Salman, what is your experience in Middle East? What's happening with in terms of diabetes? Is it?
So diabetes, we have one of the highest prevalence in the world in type 2 diabetes, and same with obesity. And sleeve gastrectomy, like the rest of the world, we have, it's the most common procedure. We are suffering from obesity like the rest of the world, but I think, again, I need to, focus on science with technique, because I think, yes, sleeve is a good option. You can tailor it with time, but you have to make sure that you have to do it the right way, prevent complications, and also for diabetes, you have to have a score for that. And even the group from Cleveland Clinic, they have a score when to choose a sleeve versus when to choose a bypass. So we have to tailor the procedure according to the patient. So the patient input is very important.
Okay, thank you very much. Big round of applause to both of them. It's a deuce, so there's no ball to any of this. Okay, go away. Thank you very much.
All right. I'd like to invite the next two. We have Kazu Kazunori and Vidal Joseph. They're going to talk about new bariatric procedures are necessary to achieve better results. Again, standard bariatric procedures are enough.
Thank you, Camila, for giving me such easy topics for me. I don't need to use my karate now. And my topics is the new bariatric procedures are necessary to achieve better results. This is crucial. A new procedure necessary? Absolutely, yes. Because the world is changing, so that day by day. So 10 years before, we couldn't imagine such kind of things happened. So, Dr. Vidal, which phone do you use? If you use such a big and heavy phone or old-style BlackBerry, you can deny the development. But if you use smartphone, you cannot deny it. So I'm talking about innovation. So in the era of iPhone, it's always developed. First, I bought the one 2007, and then second one 4S and 7, and now use 8. And if my wife allows me, I want to buy a new one.
I got it.
So the history of bariatric surgery, it's starting from GJ bypass and gastric bypass, BPD, and stapler procedures, and gastric banding. But now, the approved procedure now is banding, gastric bypass, BPD, sleeve gastrectomy, and the one osmosis gastric bypass. But you should know these old procedures used to be a new procedure. So that the reason for the innovation is searching for the better result and the risk reduction that fulfill the patient demands, because there is no perfect procedures now. So we have some problems of each procedures. Gastric banding almost abandoned now, and gastric bypass, we have some drawbacks. Especially our country, we have a lot of gastric cancer, so that we cannot do a gastric bypass. In the BPDS, it developed malnutrition, and sleeve gastrectomy, drawbacks is girls, and still, one osmosis gastric bypass is not allowed in United States. So new procedures, like a study, is, I think it's, improvement procedure. to risk reduction from BPDDS, and the SASI is also a procedure after BPDDS. And our region, Asian Pacific region, is a 3+ procedure as now getting popularity because we cannot do a gastric bypass. So gastric bypass without bypass the stomach is a 3 DJB procedures. And the loop DJB and the bipartition and the loop bipartition, of course, there is something new. And also that we are developing endoscopic procedure like endoscopic gastroplasty and the balloon and other kinds. So don't stop development. Of course, the most important things to developing new procedures are safety and ethics. We cannot deny that. It's very important. And don't do quest for fame to be a bariatric legend. We don't do a new procedure to be a bariatric legend. So a new bariatric procedure necessary to achieve better results? Absolutely, yes. However, we cannot forget triple E. What the triple E means? Triple E is ethics, evidence, and education. Thank you very much.
So thank you. I think that we will agree. I mean, basically, I have an iPhone 10, so it's not that I'm against innovation. That's clear. Let's make that clear to all of you to start with. So these are the standard bariatric surgery procedures that are available, that we are performing or you are performing. And these bariatric surgery procedures are backed by a large amount of data showing the health benefits associated with bariatric surgery doing these procedures. Obviously, these procedures were new at the time, and they are not new anymore. But the important of that is that these procedures are supported by a large number of studies showing the benefits. One of the problems the field has, and this is something that I pointed out already in the revisional surgery debate, is the heterogeneity of what we do. And Walter Porteous nicely depicted this issue. So yes, I had a gastric bypass, says that lady, or the doctor to the lady, but which one? So what variation of gastric bypass did you have? Well, the work was done for me for this presentation by a consensus panel that was held in a meeting called the Bariatric Metabolic Surgery Standardization World Consensus Meeting. So something like that was needed, even for those well-established bariatric surgery procedures. For something as well-established as standard gastric bypass, there are different limb lengths. I oftentimes listen that name metabolic gastric bypass. I don't know what exactly that is. I don't know exactly where the evidence for that is. Banded gastric bypass, one anastomosis gastric bypass, diverted one anastomosis, single anastomosis gastroileal bypass. These are the definitions under the gastric bypass that were encountered in that meeting. For the sleeve gastrectomy, 10 different procedures. So, surgical variants overlap indications, and there's very limited comparison between them. And there are also reporting problems, and this is not an issue only with the new procedures, but also with the old procedures. So we need a standardization of surgical outcomes. So the question really, to my mind, is whether we stick to the proposal by Platon or we stick to the proposal by the Nobel Prize in Physiology, Sen-Georgi. So Platon, back way, way back said, wherever the art of medicine is love, there's also love of humanity. So that leaves room for creativity. Whether more recently someone said the work of science is essentially to measure. Well, what did the surgeons and other doctors in that meeting said? Well, the diversity of procedures characterize the imagination of its practitioners and vitality of the discipline. Vitality is obviously something that is good. Creativity is also good. I'm not sure imagination without measurement is something that is as good as the other two things.
You have 1 minute.
In that same setting, they said, I'm almost finished. We metabolic surgeons are working in an era of evidence-based medicine. And I agree with my opponent that is where we should be moving to. As surgical scientists, we must report a consistent technique to facilitate reproducibility and comparison of results. Standardization ensures a level of scientific uniformity that strengthens surgical practice, and absence of standardization results in a weakening of the quality and utility of the evidence base that impairs our ability to improve patient care. So, I think that neither technique is sacrosanct, and this applies to sleeve gastrectomy, who was started in 2004 and now is the most commonly performed technique. But the value of a new technique can only be learned from the evidence of formal research, which depends on the collection of precise and reliable data. And this is where I'd like to see the field moving. I'm fully for new techniques, safer, and showing better results, not only for what, as you said, a quest for being, for having a name in the long list of founders of different surgical techniques. Thank you for your attention.
Thank you. For the sake of time, you can make one comment, Kasama, but we need to move on. So let's put the voting system, and we will have to continue to the next presentation. Kasama.
Okay. So thank you for a very nice counter. Yeah, I agree with the surgeon, with the medical professional, how to working on the evidence. But you imagine that 10 years ago, there was no level 1 evidence, before Stampede trial and before the Lubino trial. So the surgeon who tried to create new procedure have to establish new evidence, right? So that, of course, there's no high-level evidence regarding a new procedure, but we are trying to make evidence. Okay. And so we are not so satisfied with the status quo. So there is some place for to be improved right now.
I think that the results so far are pretty good, and we should be performing what has proven good so far. And on the other hand, there's room for creativity, there's room for new procedures, but I'd like to see as a first paper for a new procedure a randomized clinical trial comparing to an established one. So a variant of sleeve gastrectomy compared to standard sleeve gastrectomy, and not just a case series of the new procedure without comparison. Whenever, as physicians, we have our drug company develops a new drug, it's usually comparing to an existing one or the common practice one, not just a series of cases of the new one. So I think that there is room for new things, but it's not creativity, it is not art, this is science. And that's my only point. But I obviously see room for new procedures to come in the next years.
Thank you very much. To do opens. Oh, Kasama.
I know that everyone here uses a smartphone, so that
no time. Thank you. The next speaker.
So I will call the next debaters, Dr. François Batou from France and Dr. Mohit Bhandari from India. Topic is one, anastomosis gastric bypass will have more complication than it appears.
Dr. Batou, please.
Okay, thank you for the privilege of the podium and for the privilege of starting this debate. So
close to the microphone.
So first, I would like to acknowledge that it will be tough to resist to this Indian bull. I didn't know that it was bullfight. I am the Buabali, Buibalu that will resist to the one osmosis wave. So I will start first, of course. To remind that even the IFSO, which was this summer meeting to envision the future, was very recently publishing a very cautious word that, of course, this operation seems to have many interesting avenues, but still, little data in the long term, some risk ahead, so a lot of cautious on a need for more study. So we don't have much time, so I will focus on my main argument, which is fact, which is a randomized trial that was performed in France. I will not go through the benefits, because I'm sure that my opponent will do that. So a little bit more weight loss, a little bit more glucose control, but not significant in a 200 patients trial. So not a magnitude which is huge. But what we already know is that there were more nutritional complications with OHGB. And that's something which is worrisome. Of course, it was not published before. There are several other studies that did not stress that point. But this was an independent reviewing of the complication by the independent review board. And this was enough to have a warning official message by the board of the study. So let's keep it simple. So I think we need to see this operation as a simple anatomical trick. You know, it's just basically very similar. So what we have is we have ABC. We have some green, which is the biliary. We have some red, which is the alimentary. We have some blue, which is the common limb. Common limb is driving the glucose control. The shorter, the better. You can go up to the duodenal switch. The biliary limb, SIM, I will come back if you want later, will drive the weight loss. But we have something which is denutrition. And it's obvious that denutrition is increased when you decrease the length of the sum of red and blue, meaning that the Roux-en-Y is protecting you because it's absorbing not glucose, but amino acids. This is just not big science, just mini pig study comparing SHAB, OHGB, distal OHGB, and distal OHGB, where the common limb is the same. Just simple code color. Red is bad. Red is deficiency in amino acids. SHAM does little thing. OHB is increasing deficiency in amino acid. The more distal, the more deficiency. A distal OHB does not do that. This is important to me. This is facts. This is important. There is a rationale for that. The next point is that these cases are maybe case report, but anywhere in the world, I'm pretty sure that any pathology center or referral center see more and more of these cases. Disaster, liver failure, protein denutrition, risk of death. That's important. Maybe it's not every single patient, of course, but it's even 1%. It's a huge number of patients at risk. So we have to be careful. They are piling up in literature and in the real world. We see them. We saw them twice this first 6 months of the year coming from other centers. Second point is mobile reflux. I will not go with the cancer. I know that there is a rat study, but it's old study. I just say that in the Maud Robert's French study, when they did routine endoscopy, 2 years later, in these patients, they just saw more bile. That's obvious. They saw gastritis, they saw esophagitis, they saw a little bit of metaplasia. 2 years, this is very little, 200 patients. But look at what is going to happen. This is historical finding in another world. It's the world of gastrectomy, not so far away for duodenal ulcer. A gastrectomy, Billroad 2 versus Roux-en-Y, looks very similar to our problem. It's 20 years later. When you go 20 years later in the Billroad 2, which is a one anastomosis, you will have 50% of abnormal gastroscopy versus 10% in the Roux-en-Y. You will have Barrett's in 25%. You will have intestinal, not intestinal metaplasia in 20% of case. This is something you cannot hide. This is existing. 10, 20 years, not a long time. These patients will go there. And more will come. Just few examples. I've been here for 25 years and I've seen 3 times the story of the new operation, which is easy, we have no complications and a better weight loss in the long term. More complications will happen. Obviously, secondary hyperparathyroidism, osteoporosis. This is a nationwide French trial, French survey with more than 20,000 patients, very well matched. There is a clear, after malabsorptive operations compared with with a sleeve gastrectomy in front. After 4 years, 4 times more bone fracture, significant bone fracture in malabsorptive procedure. You will see them. Just measure PTH. It's increased after 2 years. After 10 years, we'll have bone fractures. Kidney stones. In the Baud-Robert paper, there was 3 kidney stones, only in the group of OHGB. 3 out of 100, 2 years. Kidney stone will come, kidney stone will go. It goes with hyperoxaluria. Been there, seen that before. Now I'm dealing with malabsorptive surgery. I'm dealing 20 years later with end-stage renal failure, indications for kidney transplantation, and that's what I'm seeing, patients 60, 70 years old with these problems. So to make my story now finishing, take-home message, efficacy, maybe slightly, but slightly, not enough to be striking in a 200 patients trial, randomized trial. Risk, for me, I'm talking about risk. I'm not talking about clinical evidence. Risk is there. Risk would be for the future, is superior for IGB. So I don't know what we will, at the end of the day, say, but what I would surely do, I'm not against anything. I'm not against IGB, but I will surely respect this 4 points. I think at this time of the knowledge, we should reserve OHGB for the patients with higher BMI. They have less risk of the nutrition in the long term. Second, you should avoid OHGB in patients with any kind of severe GERD or Barrett. Do endoscopy before. Finishing there. Keep the common limb long enough. And I don't want to talk about 200 centimeters. This doesn't matter. It's a percentage. If you have a short lady with a 3-meter bowel that exists, you will have short bowel with a 2-meter with 150 centimeters. And finally, on forced lifelong endoscopy and lifelong follow-up. You can do that if you are able to enforce lifelong follow-up. You will have problem for sure. And I'm here, I'm done.
Okay, Mohit now. Thank you, Francois.
Okay.
The other presentation, please, Mohit Bandari.
I think Francois has already lost it because he says OHGB is more efficacious than the gastric bypass. Can I have my presentation, please? Everything what he said, we have been fighting for mini gastric bypass since decades together, and everything what he said in his presentation is having a solution in my presentation. Let's go ahead. Greetings. I'm not going to go into the details, but this is very important. I would want to know how many number of procedures somebody has done before debating the procedure. We do all the 3 procedures at our center. This is my mixed disclosure. IFSO wants us to do it, and I do all the 3 procedures. So I'm not defending mini gastric bypass as a cult, but I'm defending it because of the evidence, because of the publications, which shows that the procedure is much more efficacious than a mini bypass or a sleeve, than a gastric bypass or a sleeve. We see this is the indication. We do not do it in all the patients. So BMI more than 50. More duration of diabetes and GERD and liver disease still remains a contraindication. So it's not something which we are doing it out of our own response. You see that there is a tendency, and that's what Francois is doing. He's rejecting a new theory just because he thinks inside that that's wrong. And that's known as the Semmelweis reflex. And we know that when there are paradigm changes, they are met with a lot of opposition, and that's what is happening. So what has happened in the field of bariatric surgery? When we thought that gastrectomy is giving us good amount of weight loss, we derived a gastric bypass because there was no weight regain. And that's what this fellow did. Forget about his personal behavior, but the project of mini gastric bypass, the procedure, is one of the most efficacious procedure. That's what he did. He did simplified the gastric bypass. The mini gastric bypass is a simplified form of a gastric bypass. And that's what has happened. But unfortunately, despite long period of 20 years, the procedure being performed all across the world, we still have a controversy. It's a long gastrojejunostomy, a low-lying gastroenterostomy, wide, easy to perform, no tension on the anastomosis. This is how it looks, not like the gastric bypass where you have a high-up anastomosis close to the GE junction. These are the publications. It's not a new procedure. These are our publications. A lot of centers have published, and there were several thousands of MGBs performed, and Camilo has kept a debate, is it a standard procedure? I can't understand that. You see, you talk about Europe, you talk about America, you talk about Asia, you talk about America, you talk about any part of the world. Thousands and thousands of mini gastric bypasses are performed, patients gaining benefit, patients bringing their own patients. What do the critics talk about us as Francois did? They talk about the protein energy malnutrition, bile reflux, marginal ulcers, malignancies, the new Omega trial, and the animal studies demonstrating the protein malnutrition, and so on and so forth. Let me justify. The Omega trial, the problem here is the length of the bypass. Despite one of the proponents in France explaining them not to bypass 200 centimeters, the study was conducted with 200 centimeters of a bypass. And that's what Kamal has wrote. We have to actually see the studies of Omega trial with a lot of caution. It was a nice study, but the problem here is the length of the bypass. It's 200 centimeters. Are the results same with 150 or 180 centimeters? No, they are not the same. So the problem was the length of the bypass. Now see our own data. Exposed to Rutledge, we were doing 250 centimeters as a standard and then shifted to 180 centimeters. And you see everything, what Francois talked about decreased. So the length of the bypass is the problem. Marginal ulcers, no, the incidence is not more than gastric bypass. It's in fact less in most of these series. Talk about bile reflux. The bile reflux is just thought, the bile refluxing into the stomach or the gastric pouch and the bile refluxing into the esophagus are two different entities. And that's what most surgeons opposing mini gastric bypass does not understand. Bile refluxing into a gastric pouch is normal. Bile refluxing in the esophagus is not because of mini bypass, it's because of the defect of lower esophageal sphincter. And so, when we talk about bile reflux, it's not causing problems, it's just that they postulate it can cause malignancies. Now let's come to the malignancies. The gastric cancers in bypass stomach, just one case reported, and there are several cases reported after sleeve gastrectomy, but nobody would talk about it. 2 cases reported after mini gastric bypass, and all these cases, we know that when we compare MGB with RYGB, most of these studies have shown that mini gastric bypass is much better as compared to RYGB, not only in terms of the weight loss, but also in terms of the quality of life. It's a simple procedure, shorter operating time, lower operation risk, easy to reverse. And then let's see our own data. We have no difference between the banded and the mini gastric bypass at 1 until 4 years is huge. You see there's a 7.48% difference, so it's much better. And if we compare the banded bypass, the conventional bypass and the mini bypass in our own data has shown more weight loss, more diabetes resolution, more comorbidity resolution. In the end, I would conclude that imitation is the sincerest form of a flattery. So, ladies and gentlemen in this hall, the concept of compartmentalization of intestine is gone. We are now going towards a single anastomosis, simplicity, more benefit. And you see all these procedures, loop DJB, SASI, SADI, SAGI, what are these procedures? They are imitations of mini gastric bypass, simplifying the gastric bypass for the betterment of the patient. And last but not the least, the IFSO accepting the mini bypass. And we have a special session there where we have all the guidelines set in for all of you to see these guidelines which experts from across the world have done and formulated for all of us. So I would conclude, MGB with a 150 centimeters to 180 centimeters BP limb is a good procedure, safe, simple, effective, reversible, and you can judiciously perform with an algorithm at your center. Thank you very much.
Thank you very much, Mohit. Very nice presentation. Francois, you have only one comment because we are way ahead of time. We are in a big trouble.
Okay.
Antonio is looking at me.
My next
well, the slides from...
Only one slide. I skip my comment on centimeters. It's just technical, but I think it's important. The answer of centimeters is not the right one. The point I wanted to make that I was not impressed. I thought I would be more impressed by the difference in efficiency. It's little. So what is the benefit of this operation? Is 1 or 2 hours less in the OR. What is meaning these 2 hours? In my job is not anymore bariatric surgery, it's bariatric medicine. I become someone who is changing life of people for their lifetime. So 2 hours, lifetime. I think we need to get out of this technical 1 hour easy operations and to focus on the long term. And I think this is very important. So my slide, if I just have it, is just, I'm not against, very good for some indications. I was happy that we are very similar. Length, everything you said, follow-up, I agree with that. This is not what I see. And what I see is complications. What I think is, if I can have my slide, I just have Warren Buffett.
Back to this presentation of Dr. Patou.
This guy who is earning a lot of money by investing slowly and carefully. What he says is that never put your 2 feet in the water at the same time. Be careful. We are not playing with money here. We are playing with 1 hour in the operating room, lifetime. Osteoporosis will be a huge problem, 20 years. I've
Microphone.
Been there, done that. 25 years from now, we'll be back. This would be tough. And this is tough now to take
Microphone.
care of these patients. I mean, 25 years later, I've been there 25 years later. I've seen this incredible operation, biliary, and now I see that. Kidney stone, kidney failure, denaturation. This is tough. Bariatric, final word, we are doing bariatric medicine more and more. This is lifetime. This is not about 2 hours. And I think it's important to focus on the right thing. The right thing is be careful, think long term. Careful with the one-on osmosis. Keep it for the right patient, with the right technique, not too fast.
Lillian, one comment, because Asia has been the strongest one anastomosis gastric bypass growing region. What do you think about that?
I think it's an option, and as our speaker last said, you have to choose your patients. Selection of patients is very important, and we await long-term results.
Okay, thank you very much. Very nice presentation to both. We need to move to our last session. Oh, Patu won. Oh, that's good. So you win our last bull, then we don't have left. Thank you. Okay.
Professor.
Well done.
Thank you. Thank you.
Okay, and we are coming for the last presentation. Antonio, you need to moderate this because this can be complicated. You are the official host. So on one side, we will have Dr. Ricardo Cohen. Here, Ricardo Cohen is going to defend the position there are many. So we're having here some kind of problem here, but any of you have to present here. So whoever is the leader here has to present. We can have the slides from the Okay, so you have 5 minutes, okay? Whatever's...
They changed the contenders and stand against one. Okay. Manuel, you look better with a mask. Go on. Yeah.
Okay, the slides, please.
He looks better with a mask, yeah.
Surprise, surprise. So we are here to talk about a procedure that has been developed recently. It is called endoscopic sleeve gastroplasty, an endoscopic way to treat obesity. And what we are presenting comes to fulfill a need and a gap between the patient's benefits from more conservative treatment on obesity and the ones who qualify for bariatric surgery. And the ones who qualify for bariatric surgery, only 1% of those get this. So our vision is that endoscopy, together with the new medication, can fulfill this gap and help the patients. Just take a look on this brief history and timeline of this procedure since 2012. It was done very responsible under IRB trials, and then it goes on the clinical practice based on the very good results and the safety profile. As you can see here, when you got to 2015, more reproducible series, large series, 2-year series of 1,000 cases done, and the numbers now is around 15,000 with an excellent safety profile and around 15 to 20% of excess of total body weight loss. So, as you can see here, as we speak, the evidence is building. Every single month, we have a new publication, new series attesting the benefits of this on a clinical practice. And you can see here some pooled data and check by yourself the numbers. That is more than 1.5K cases, results at 12 months, results at 2 years, and these are the complication rates reported. And this data is being very well considered at the point that meta-analyses are done over these results. And you can see here, this one is originated from China. They don't even have the device there, but did a very good job in analyzing the data that you provide in a very ordered manner with prosperous guidelines. And you can see here they found 9 papers. Those 9 papers are going to guide you to 12-month results in a pool of 16% of total weight loss. They also scrutinize us for complications. And you can see here the less severe complications, that's the number. If we go to severe adverse events, those are the numbers. Look by yourself. So our group also have provided you with another meta-analysis. Well done on when the name and the sake of a good science. So what you can have here, again, is a very structured meta-analysis, and we could find papers up to 24 months. And those are the data, so very strong, reproducible data. And as it is a very young procedure, we will continue generating the data for you. As we speak now, level 1 data is being built. And you already know by the debate, level 1 data is very rarely presented on the field of bariatric surgery, unless we have big trials and big funding. So you see here, this is an FDA trial done by surgeons and gastroenterologists. After the end of this trial just ended enrollment and is guided by Professor Bahram Abudaye and Eric Wilson. You can see here the institutions that participate on this trial. I'm going to name some like University of Texas, Cornell, Harvard, Hopkins, together with community centers. So this is a very well-designed, 200 patients. 80 are going to be already randomized for the procedure, 120 for the clinical treatment, and they will be crossed after 1 year. So for a young procedure like that, generating that kind of good data, and the promising results are so well replicated, we are very comfortable to use that on clinical practice. We are seeing more and more the presence of bariatric endoscopy among us. And what we can predict, just be a little bit smart. Look what happened with cardiac surgery. Ask the question we should do is, where are the cardiac surgeons nowadays? Almost completely replaced by the endovascular methods. So we're sitting here together and say, this is going to die, I'm going to kill, it's going to go away. It can't go away. We're not going to go away. We are here to work together with you guys. And look what we have covered in these 5 years, the literature. So this is an organized effort to present to you in another way a new possibility for your patients. Patients that don't have access or don't qualify for surgery, they are underserved. And this is a clear need for a procedure. But unfortunately, we have some people that they think different. And instead of giving us good data, they react badly. That's what we can expect for our next presentation. Unfortunately, publication that claims that they did a systematic review. That's no structured systematic review. Don't even follow any guidelines. They created their own classification or grading the papers that the meta-analysis, when submitted for the structural analysis, they included, and they, misses and forget, and you see, not even taking care, not even paying attention, blasé, but you know what? Ignorance. Ignorance means not a bad word that you ignore, and then you mix apples with pears. So they mix two procedures.
1 minute.
Put together. I'll finish in 1 minute, don't wait. By the way, darling, you leaked some information. We're gonna get you later. You're here. It's a rat. So
I'm a
they
professor.
did on purpose, they try to fool you. It's like the same of comparing result of sleeve gastrectomy and by, no, different. They are trying to compare results of circular stapler with linear stapler. Can you compare that? And by the way, there's a mention of 10% complication rate fabricated. This does not there in the literature. So, as you can see here, and finish what you have to do, we have to do some questions. We answer back with science. UT, Harvard, Hopkins, another meta-analysis to answer this paper. And they answer back. Again, they answer back, or the forces answer back. And it ends like with this quote, that without data, you're just a man with opinion. They end like this. So I offer you to judge who has the data and who is the one who don't find the data, who twists the data, and most of all, declare no conflict of interest.
Thank you very much. Manuel, can we have the other presentation? You had some...
Can I have my slides, please?
Okay.
I'm debating with 10 different people looking at me with masks. They look better with masks. And is endoscopic plication, because this is a plication regardless of the method, dead? No, it's not dead. Those are my conflicts of interest. They were disclosed in the systematic review that we've published. But there's no debate. They're outside the law. Who's not familiar to the Casa de Papel thing, this is what they deserve. So, what we do with criminals, we arrest them or we kill them. So, we have to think about this. Anybody here thinks that mid and long-term restrictive procedures have good short-term, mid-term, or long-term effects? Remember the bending, remember the laparoscopic gastric plication, remember the VBG. They don't work. Well, I have to remind my good friends with masks that what is a level of evidence? This is the Cochrane's suggestion to consumers who want to publish. So RCT is the pinnacle of evidence, level 1, or number 1 in the Cochrane thing. K-series, regardless of the number. Retrospective series, regardless of the number, are 5 or 6. So it's 1, 5, or 6. Oh, everybody in the same page. Let's torture data because it will confess it. This is a Nobel Prize quote. It's not mine. He's much smarter than we are probably. Look at the gang's paper. They had 8 studies, most of them retrospective and prospective single-arm cohorts. They used the MOVES reporting thing that came from a consensus statement. Consensus statement evidence is by itself level 4. So they're reporting their data with a level 1 way of reporting it. And my way of reporting was awkward. It was the Joanna Briggs systematic review for retrospective studies. And there's publication bias because there are methodological issues in retrospective and prospective cohorts. But look at this. This is the same meta-analysis that my contender presented. Study quality, 5 or 6. 5 or 6, not 1 or 2. Well, there are 2 RCTs. Yes, there are. And if you plicate with the pose or with stitches, with 4 stitches, 3 stitches, the same concept is gastric restriction. So the essential trial with 338 patients comparing medical treatment, poor medical treatment, because it was lifestyle interventions, versus the plication. Both arms did not reach the primary endpoint of 5% of losing weight. 5%. There's the milepost, very tiny study, and I suggest you to read my paper again because the studies are there. They have 44 patients, 22 in each arm. The total body weight was for 13%. My friends, be careful. This is the semaglutide data for obesity. Look at the numbers. 16% of weight loss in a phase 2 trial published last year in Lancet. 16% with an injection. Click. No plications, no stitches, no bleedings, no perforations. So we need to avoid undermining our reputation. And they really have very short follow-up. The follow-up is really, they lose patients to the follow-up. It's a mean of 6 months, 17 months, 24 months. The window of follow-ups is very loose because they need to have the patients with them. Why? This is why. They don't work. Look at the stitches. This is an endoscopic gastroplication 6 months later. Well, endoscopic plication, it's not dead at all. It was not born yet. It needs data to be at least born and then come back to us and say it works. Again, this gentleman helped to reconstruct Japan after the Second World War. And he used to say, Mr. Japanese government, you want my money? Show me the data. Thank you.
Please, I think this is very important now. Put the voting system on one screen, and on the other screen, please put again the presentation of Dr. Galvao, and please start voting. We are going to keep on voting for the last 10 minutes of discussion. Manuel.
Well. You see, he did exactly as I anticipated. He lies. He despises. He twists. Again, he tried and put apples and pears. He's trying to fool you guys. He shows data for a procedure that's not even done more. And I present data about what we are doing. And he's twisting you. And data is not enough. This is the voice. That person there, that anticipated the death of sleeve gastrectomy years ago. Those are the shadows that don't allow the mini gastric bypass to see the light and to be respected despite all the data. For those kind of person that try to put Michelangelo on the fire, those guys, they are there forever. And we have to face them with the powers of the people, and we will show you data, respectful data, of a young procedure that cannot reach what procedures with 15, 20 years had. We're gonna get there. But look at the face
take the mask.
of the
Manuel.
section, the face who twists the data, showing that what data he presents. He have just opinion. We push them, and he reacted exactly the same as we expected. An opinion, lies, twisting data.
Okay.
Oh, by the way,
Ricardo.
Camilo, let me show you the faces behind the mask.
Okay.
Ooh.
Oh, lot of people. Okay, 2 minutes of reply, Ricardo.
The slides, please.
The slide of Dr. Cohen.
The slide, please. All I humbly ask is show me the data, nothing else. The slides, please. Not those slides, my slides.
Manuel, go to the microphone, or Conrad, someone? Okay.
No, the slides. I need 2 slides.
Two slides.
The slides, I want back the slides of Ricardo Cohen, please. Okay. One question, Conrad, now. I've done we've done around 200 endoscopic sleeve gastroplasties.
They changed. Now it's gone down.
Hello, nice to meet you. I just arrived. So the thing is...
No,
the first slide.
Are you making a question?
The slide first.
My friends, obesity is a chronic and progressive disease. Although the uptake is low, it's not because surgery or even the medical treatment, semaglutide, is much better than any endoscopic procedures. We need to identify the causes. That is basically that obesity is not recognized as a disease. And unproven options may undermine our reputation and to grant access to those in need for the best available treatments. And for sure, today, it's not endoscopy. Well, please, quoting John McEnroe, 7 Grand Slams. Gontran, Manuel, everybody, you cannot be serious. I'm okay.
Conrad, I was asking
How much time? 1 minute?
Okay.
Well, I think, in my opinion, this is a stupid comparison. This is a stupid debate. We could be another 20 years talking about who has the better technique, but at the end, all of us, the whole auditorium and all of us, we have the same mistake. And the same mistake for obesity treatment, surgical and endoscopy, is the same. And this mistake is low penetrancy in obesity treatment. We are talking about epidemic disease, chronic progressive epidemic disease, with 1% of the population treated by surgery. We have to do things to reach more people. Otherwise, we will die at the same time of the patient, and most of the population of this epidemic disease is untreated. Imagine this epidemic of measles with no vaccination. We know how to approach patients that are at home, not super obese patients that want to undergo surgery. Go. All my patients, I try to push them to go to a bypass. Try to do it. None of them, they won't. So there is a huge rate of population refusing surgery, but with no treatment at home. This is our concern.
I understand that point, and I always been liking, I do a lot of bypass, a lot of sleeves, and we've done around 200 endoscopic sleeve gastroplasties. Good. And what we are seeing now is that we are seeing around 15% total excess weight. That's what we are seeing. Do you agree, the whole group? 15%? 16?
Around, yeah. 15 to 20 could be.
20?
20?
20?
Well, multicentric study.
Raise your hand. 20% you're seeing in your patients at years. 20% total body weight.
Sorry, Camilo.
No, I'm trying.
Sorry, Camilo. Published 248 patients published in Madrid, San Gennaro, Mayo Clinic, and Weill Cornell, New York.
But I think, Bertrand, let me tell you something, guys, in this big debate. Do you think, given the huge epidemic problem we have over the world, is there no place for the endoscopic approaches? The problem is so huge. Many people we heard this morning we had under medication. Here you are, Dr. Salvador and Dr. Rubio, eminent endocrinologists here. For sure they are treating patients with medication. And they are very honest. If it doesn't work, they will send us the patient. And so why not combine, not be fighting one to the other? In my humble opinion, there is room for everything, because the problem is so huge that it's not a question of having 15, 16, 16.5, P less than 0.006, almost.
I think but the discussion is reasonable because, and that's what I'm saying, because we have a lot of patients coming to endoscopic gastroplasty, and I'm doing it. And my question is, what are you doing with the loose stitches? We're seeing a lot of loose stitches, but now what we are realizing is that after a year you go back, you see loose stitch, but now I'm doing endoscopy for very good result patients, and the stitches are also loose, and they have good results also. So it seems it's a matter of distension.
Well,
or
but maybe it's the era to make an endoscopic sleeve gastroplasty out of the learning curve is 30 minutes. It's the moment to do sequential treatment with endoscopy.
Yeah,
Sequential treatment is repeat suturing, repeat balloons, and at the moment where you are not done, you can send this patient.
Maybe there are answers we don't know yet. Probably the patient changed his mind. What is your opinion, Ricardo?
I think currently there's no data to support as a first choice procedure as the debate was planned.
Yeah, but at the end of the day, there is many places. So, guys, we are out of time. I'd like to thank you, all of you very much, especially to Dr. Bosa, the chairman of this outstanding and newer session in this meeting. Thank you, Camilo, for your big effort. Thank you guys, you did an extraordinary job.
Thank you for the debate.
I'm very happy to see all the IFSO family growing up in this sense.
I want a picture with Ricardo in front of all of the masks.
Okay, I think we need a picture all together, guys. All together. We have a picture. Okay. Are you ready? Francisco, are you ready? Francisco is there. Francisco is there. Yeah, with the mask. With the mask or without the mask? All together, please. Come here, guys. Christine, you're very important in this picture. Okay. So, Camilo, venga, let's go.
I'm going to do a selfie here.
Selfie, and now.
You have to look like...
Okay, let's go.